RHP7 at Central Health. Thank you all so much for being here. It's great to see so many faces I've known for a long time, and a lot of new faces. Y'all really braved the weather today, so I'm doubly thankful for that. I don't know, we are two-parent working families out there. My stepdad lives in my neighborhood, and he texted me this morning, I just saw 10 flakes of snow. And I have 3 boys, and I'm getting ready to host a large stakeholder event, and my first reaction was, no. But here we are, we survived, so thank you all for being here. I was counting it up, and we've done actually more events than this, but if you look at the large stakeholder events that we've had like this with major DSRIP program updates, this is the 10th one of these events that we've had. And I would venture to say that at every single one of these events, we've been talking about change because we're working in DSRIP. All of you all, most of you all are working directly on it. Many of you all are working, alongside it. Everyone in here is involved in some way, and it's always about change. Today, we are gathering right at the end of demonstration year 7, which is the first year of the renewed DSRIP program. We're heading into the final year of the DSRIP program as we know it today, and we're facing, yet again, a lot of change. Change in the program implementation that you're experiencing right now. And so we designed this day to really talk about what that change is, how it's functioning in your organizations, how we can manage that change for success in DSRIP and in caring for the patients that you all have responsibility for. So before we jump into our day, I want to give a brief overview of where we are with the DSRIP program right now, and kind of what we're facing as we look towards the future. So that's what we're talking about today, moving beyond the project-based DSRIP program into the real focus on population health. So just as a very brief overview, I know this is review for many of you, but these are essentially the 3 phases of the DSRIP program that we've had. Our original project-based program was from 2011 to 2016. The state expanded Medicaid managed care implementation across the whole state, created the uncompensated care pool to reimburse hospitals for their uncompensated costs, and created the DSRIP funding pool, Delivery System Reform Incentive Payment Program, which offered incentive payments for successful completion of transformational health projects. The design of it was to transform the health system to achieve better results. 2017, or demonstration year 6, was a transition year while carrying forward those projects while CMS, the Center for Medicare and Medicaid Services at the federal level, and the Texas Health and Human Services Commission, HHSC, negotiated what would be next. And at the very end of 2017 is when we learned what would be next. Another 5-year renewal. Can y'all hear me? I just felt like my voice dropped out. You're okay? A 5-year renewal of the waiver program. So through 2022, the waiver still exists in Texas. The uncompensated care pool continues that entire time with some changes. The managed care continues through that entire time. DSRIP, however, was authorized only through the first 4 years of that waiver, and funding for that is scaling down to a 0 funding for DSRIP in its current form in FY 2021. That's what we're facing. Again, we are Regional Healthcare Partnership 7. These are our 6 counties: Travis, Hayes, Bastrop, Caldwell, Fayette, and Lee. We have 9 DSRIP providers. In total, technically now, with the new change in the program, we only have 7 DSRIP providers reporting up through our region. Hill Country Mental Health Centers and Bluebonnet Trails Community Services, 2 local mental health authorities that were technically in our region before, are now reporting up through different regions. But they're still serving counties with us, and we really like them, so we claimed them. Again, these are the performing providers. These haven't changed. It's the same ones that we've had from the beginning. University Medical Center Brackenridge is now called Del Seton Medical Center at the University of Texas at Austin. Thank you, 1115 Waiver. But these are the people. These are you. So when you talk about these transitions from a project-based program to a system-based program, we went over a lot of this for those of you who attended our stakeholder meeting in April. I want to point out really what the funding difference, because how you earn your incentives is really driving what kind of work you're doing to earn those incentives. In the project-based model, you were earning incentives for establishing your project, seeing a certain number of patients, hiring providers, expanding clinics. The majority of your money was earned by those kind of nuts and bolts project work, system transformation activity. 30% of your money was earned by achieving health outcomes for the patients you're serving. But in the current iteration of the program, fully 75% of a provider's valuation is earned by achieving those health outcome targets for populations. So rather than looking at a project population, providers are now looking at entire systems, everyone they care for, and then from a menu choosing outcome metrics that they can improve for all of those people that fit those criteria. So you still need to maintain service levels. The focus of both programs has been serving Medicaid and low-income uninsured people. You also get 15% of your money simply for turning your data in to HHSC, reporting that data. As we all know, that takes a great deal of resource to do correctly. So that's really what the main difference is, which makes a lot of sense if you think about what the original intent of the DSRIP program was, transforming the system so we can achieve better health for patients. Now, we're putting our money where our mouth is. We only get paid in this new program when we achieve those health outcomes for patients. So achieving that better health for populations is at the core of what we're doing. We talked about this in April when we presented our RHP plan for demonstrations year 7 and 8. The themes of the outcome metrics that providers are pursuing match a lot what you all were doing last program. They also match our community needs, chronic disease, management, behavioral health, physical behavioral health integration. All of these are still priorities, prevention, access to care. And because in this new program, the activities of your work are much more flexible. You're not tied down to a project plan. So many of these, and you can switch them as you need to, many of those activities address both clinical and social determinants of health because we know that's what's best for the people we're serving. And so lots of great activity to hear about. And later in the day, we have a panel of DSRIP providers who are going to be talking about their experience, what's it like in this new program, so you'll be able to hear directly from DSRIP providers. And also, if you want to know more about what an individual DSRIP provider is doing, there's a packet of papers, of 11 by 17 or maybe legal, on your tables that gives information about specific metrics providers have chosen. They're also displayed on posters in the back of the room. So feel free to look around and check those out and seek out those folks that are here from the different providers to learn more about what's specifically happening in their organizations. Now, one question I often get in doing this work and transitioning from projects to systems is what happened to the projects? Did they just poof, disappear? The answer to that question is a resounding no. For the most part, we at Central Health as Anchor, we surveyed the DSRIP providers to find out what is the disposition of the projects and how are they transitioning into this new realm. We had 64 projects represented in the survey. 59 or 92% of those are continuing, either as they were originally designed or modified, or at least partially part of those projects are continuing. And which, considering how much work those were, that's a real testament to the good ideas that you all put in place. There was a lot that is still continuing. 5 projects were discontinued, and just a reminder, those projects discontinuing shouldn't be seen as a failure in any way. These DSRIP programs in the first iteration were really pilots. They were ways to test ideas, and I know in discontinuing projects those were really difficult decisions that providers had to go through so they could redirect resources where it made most sense for the patients that you're serving. 28 of the ones that are continuing were expanded to even larger populations. So those good ideas were able to spread. And remember, to do this, providers were able to take these services and incorporate them into their operating budgets, find new sources of funding. So they've been working very hard over the last 2 years figuring out how to sustain these good ideas. And finally, this last point I think is very interesting and kind of speaks to the complexity and the amount of resources needed to really make this transformation in our health system, is that of the projects that continued, only 21, or 33%, relate directly to a current outcome a DSRIP provider is working toward. And to me, what that means is, even though it's not directly supported by DSRIP anymore, providers are still finding ways to continue that work. It also speaks to how different the new program is, even though I know the state, they tried to do their best to keep things as aligned as possible between the two programs. There's still a lot of difference when you shift your thinking from projects to full system change. So let's talk about the money. I mentioned this in the beginning. I don't know if you can see that we are right here between the first 2 green bars today. The Texas DSRIP funding pool statewide is at about $3.1 billion. That's what's able to be earned throughout the state in the DSRIP program each year of these first 2 years. After, in FY20 or DY9, that's when we see our first DSRIP reduction. And FY21, DY10 is the final the next DSRIP reduction. This is about a 6% drop. This is another 14% drop. So that 2.49 billion is about 20% lower than the 3.1. And then we go down to 0. And one thing to remember too, these numbers are all funds numbers. The DSRIP program is funded jointly by local funds and federal. So this 3.1 billion is a combination of local and federal. What CMS is doing when it's reducing authorization for the DSRIP program is it's reducing authorization for the federal funds. So there will definitely be conversations about what's coming next that involve those local funds as well. If you apply those same percentages to RHP7, this is what we're looking at. So for our 6 counties and the providers here, valuations add up to about 176 million. One more year of that, we're talking about how today, spending time talking about how we're going to earn that money, and then we drop here. Again, about 40% of this is all local money. 40% of $140 million is $56 million. It's not leaving the community. How it's going to be directed, though, is still a big question. So I want to talk about some transitions. Again, DSRIP basically equals change. We have 2 transitions that are coming up. We have transitioning from DY7 and DY8, which is where we are now, to DY9 and DY10. How is the program going to be run when we step down the funding levels? Right now, we don't know. The other transition we're facing is DSRIP is going to go away. What is going to happen next? Again, lots of questions there, but we can talk a little bit about what we do know. So first of all, in moving to DYs 9 and 10, basically all we know right now is that funds are going down. We don't know much more than that. We don't know how providers will earn incentives. I will guess to say that it's going to look very similar to what you're doing now, although you will be earning less money in some way. We do know that HHSC is expected to put out its draft program rules for DY9 and 10 this month. So we should have some more information about what they're thinking. Those rules aren't due to CMS until next March. So it'll be a while before we are finalized, but it is, we are going to be getting some new information on this soon. Now, after DSRIP ends, this is another big question, and many, many groups across the state, politicians, associations, all of you all in your organizations are wondering what's going to happen and what are we going to do together to assure continuity of care. Well, one thing that's going to happen is HHSC, as part of the terms and conditions of the waiver overall, the waiver renewal, has to submit to CMS what they call a DSRIP transition plan. This is actually a plan that HHSC has to develop its own milestones to show CMS how the state is going to continue and sustaining DSRIP innovations and initiatives that without DSRIP funding. So this is going to be fascinating, I think. We know from CMS that their expectation, because all of the DSRIP funds are Medicaid dollars, CMS's expectation is that DSRIP innovations that are successful should be incorporated into Medicaid managed care, and then those deliveries can be continued through that environment. And that makes a lot of sense for populations covered by Medicaid. I think a challenge that we're facing in the state is that there are so many people in the DSRIP program that are uninsured, and so what will happen to those folks? That is and that's a question. We don't really know. There are efforts afoot to develop post-DSRIP ideas, and you may have heard some of these. You may be planning some of these. Central Health is definitely trying to keep the pulse on what's going on. One idea that has been getting a lot of attention lately is, has anyone heard about the amend and extend proposal? That's just, how do I put this? It's not an official proposal out there yet, but it's one where people are talking about. And the overall idea here is that after the end of DSRIP, negotiate an extension to the waiver that would provide coverage for low-income populations. And that coverage, and to make it work politically here in Texas, it would be thinking about things like not making it an entitlement, having it being run in the private market. But a lot of people are thinking about how can we expand coverage in the state in a politically viable way for Texas. And so there's going to be a lot of thinking about that. Even after DSRIP ends, budget neutrality remains. That just means that when you look at the entirety of the funds that are authorized in the waiver, that is still available to the state. CMS is open to proposals of new ideas. HHSC is open to those coming. And so I think what you'll see is in the development of this transition plan that HHSC is working on now, and in the 86th Texas legislature, which begins next January, this is going to be a big topic, trying to figure out what's going to happen next with these dollars. HHSC is asking for stakeholder input onto their transition plan proposals. They'd like to see their first round of input by the end of this month. So it's a pretty quick turnaround. But it is also not the only time to provide input here. So these ideas are going to be discussed at length over the next few months. So keep an eye on that. And then here is just a timeline that kind of describes what I was just talking about. The top line is the timeline of what to expect for the DY 9 and 10 implementation. We have those, HHSC has to submit program rules to CMS in March. CMS is supposed to approve those by May. HHSC then submits the measures, the outcome measures that providers will be choosing from. CMS approves that by September. And note, DY9 starts right here. They also expect, we'll be doing another RHP plan update the first 2 months of DY9. So again, DSRIP equals change. It also equals it sort of after the fact. We're a little behind on our timelines, but it's there. And then here, this is when the first draft of the DSRIP transition plan for the state is due to CMS. The final draft is due next October. So keep an eye out for all of these moving parts. It is a lot, but it's always been a lot, so it's really nothing new to the folks in this room. So what I'd like you to do now, if you would with me, is I'd like you to come back into this room, take a deep breath, let it out, and remember what Dr. John Kabat-Zinn, who is founder of the Center for Mindfulness in Medicine, Healthcare, and Society at the University of Massachusetts Medical School. We can't stop the waves, but you can learn to surf. So we're here today to surf together, to figure out how we can keep ourselves up on our boards collaboratively, working towards the ultimate goal, which is better health for our communities. So, thank you. So what I'd like to do now is turn it over to our keynote speaker, Dr. Mark Hernandez. Dr. Mark is well known and loved. I know many of you have seen him before. He is the Chief Medical Officer and Executive Vice President of the Community Care Collaborative, one of our DSRIP providers here. And the Community Care Collaborative is a unique public-private partnership between Seton and Central Health, is a nonprofit that is responsible for the care of the about 100,000 people of low-income people in Travis County, so the medical access program population and others. Mark started out as a registered nurse working for Harris County Hospital District, another anchor, back in 1993 while he attended medical school at Baylor College of Medicine and did residency in internal medicine at the University of Medical Center Brackenridge. So Mark has been here from the beginning. He's seen DSRIP grow, he's seen it change, and I've had the fortune to work very closely with him, especially in the early parts of DSRIP, and his visionary leadership and vision to really motivate all of us to move through this difficult change was really powerful and helpful for all of us as we were dealing with these difficult new policies and new ways of thinking. So I want to please welcome Mark Hernandez.
Can you hear me? Yeah, I can hear me. I can hear me too well. I'm going to back up a little bit here. All right. Well, thank you very much for having me, Katie. Thank you for inviting me to come and speak. I'm going to try to keep this short, about 20 minutes, and then I'll actually take questions, which I probably won't be able to answer, so I'll look around and find some smarter people out there in the audience and redirect the questions at you. I have been in this DSRIP journey with you since February of 2013. Out some people out in the crowd who've been doing this longer than me. Who are those people? Raise your hands if you were doing this before February of 2013. Yeah, there's got to be a few because I got brought into the work. Somebody had to convince me to drink the Kool-Aid, but then I came and joined the party. I think what you're going to spend a lot of time thinking about today, Katie kind of alluded to it, is DSRIP equals change. And I'll add another part to that. Change sucks, right? We don't like change. Humans like things to stay the same. We get used to things the way they are. We like that. It allows us to have routines. It allows us to do our work consistently. And then before you know it, you can't do that anymore. Somebody's changed the rules. Now, one of the things that DSRIP has really challenged us with, and probably to all of our benefit and growth, is that the rules never stay the same. Even during the program, even the first 5 years of DSRIP, we were constantly having to zigzag as the rules changed. And I'm not saying that that was fun or necessary. I am saying that it created a certain amount of resilience among us to be able to weather change. Well, now there's a major change in the waiver coming. Essentially, we're going to measure different things. Not how well you stand up projects, but how well you can create outcomes in a population. That's the new name of the game for DSRIP. So a lot of what you're going to talk about today is how we've learned in the past, what those lessons can help us going forward, and how do we actually become change agents. And the one thing I would stress to all of you is whether you think of yourself in those terms or not, if you are engaged in the work of the 1115 waiver, you are a change agent for your organization. So how many of you provide direct care to patients? Okay, there are a fair number of you that provide direct care to patients. There was a bigger number of you that don't. And yet your agencies, your organizations touch patients. That's the reason you're here, is because you're trying to improve the health of the individuals for whom your organization is responsible for. So why are you here if you're one of those people who didn't raise your hand when asked if you're a direct caregiver? For all of you, why are you here and your caregivers aren't? And the answer is because your caregivers are back at the office taking care of people, which is where they should be. But who's going to help them understand the changes that need to occur? It's you. That's why you're here. That's why you're engaged in this work. You have to be the change agent for your organization. A lot of what goes later today is how can you effectively be a change agent? What I want to talk to you about is the why. So you can have conversations about how you affect change. There are better people to talk to you about that than me. We can talk about the specifics of change. What should we be changing? There's probably better people to talk about that than me as well. So now you're beginning to doubt that Katie knew what the hell she was doing when she asked me to be the keynote speaker. But lest I disappoint her completely, let me tell you what I think I can talk to you about that hopefully helps you as you move forward into this next waiver, and that is the why. Why is the change important? And let me tell you, way back when, in February of 2013, when I got brought into this work, and actually it was even before then that I first heard the term, when I got told about this thing called the 1115 waiver, which took me about a year before I figured out what 1115 stood for. I just took it on faith that that had importance. Somebody finally explained it to me later. When I got first told about this, it got told to me as, Mark, this is a funding strategy. That's how it was sold to me. This is a funding strategy. And in the organization that you're going to be working in, the Community Care Collaborative, this whole project is going to be run out of the finance department because it's a financing strategy. And this is how you're going to bring money into your organization. And that was key for me because I was trying to decide whether I would take this job. And one of the questions I had for my boss was, is the work that I want to do funded? Because if it's not funded, I'm not interested. Unfunded mandates don't really go anywhere. And so I had a good job and didn't want to leave it unless I was leaving for something we could actually do. And what he told me was, yeah, about 60% of your funding is there. About 40% of it you have to earn. And you have to earn it through this thing called the 1115 waiver. And I said, well, okay, I've never been afraid to bet on myself, so I'll jump in. If you tell me there's a fair chance to earn the money, I'll jump in and help, and we'll figure out how to earn the money. But at the beginning, it was all presented to me as a funding strategy. This is a finance strategy. We run it out of the finance departments. By the way, how many of your organizations still run DSRIP out of the finance department? Yeah, I mean, I'm not surprised. In fact, I'm surprised that it's not more. I'm pleasantly surprised it's not more. But nonetheless, almost everybody started with it there. Why? Because this was about taking money we had received in one form previously and now receiving it in a different way. So why wouldn't the finance people own it? But here's the deal. I never saw it through that lens because what I thought I was being hired to do was improve the health of the individuals in Travis County. That's what I'd been doing before. It was what attracted me to the new job. I thought my job was, and I still think today that my job is, how do I improve the health of individuals who live in Travis County, Texas, who are uninsured or underinsured? Our job is to change their health for the better. That's it. the whole job. That's what my organization does. We do that through the waiver. And that's what I had to learn over the years that came afterwards. So the waiver affords us a couple of unique opportunities that hadn't been present. So one of those was the notion that we could try new things. Up until that time, we had a way of taking care of people in the safety net. Did it create great health outcomes? No. It didn't. I don't know that I would want to return back 5.5 years ago and accept the health outcomes that we had for the individuals that we cared for and carry that forward and say that's good enough. It was never good enough. By the way, it's still not good enough. It's better, but it's not where it needs to be. So this was an opportunity to say old ways don't work. We need to adopt different ways of caring for people. That always has a cost. This was the opportunity to leverage dollars to see if we could create health in this population. I think, and you guys know, we have done that. Think of all the projects you've been involved in. Think of all the outcomes that you've reported. And when you think of the scorecard, and when we usually talk about the scorecard at a high level, we talk about how much money we drew down, understand that you didn't draw that money down unless you got your outcomes. Even in the old DSRIP, a fair amount of that money rested on the ability for you to actually change the health of individuals. You did that. And you did it through new and novel ways. You didn't do it through the old ways of doing it. So that's part of it, is it gave us this opportunity to actually change the way we were going to approach care. But the second thing is, and this is a bit more mercenary, this is a financial program. As much as I've tried to divorce it in my head of this being a financial program, it is this wonderful way to pool dollars into our organizations so that we can continue to provide care to those individuals that we're responsible for, and in many cases care for more of them. You know, here in my organization, we're adding a benefit program this year. I don't think that ever would have been possible without the waiver. Can I directly point at the waiver and say that's what got us there? No. Was expanding our benefit program a DSRIP project? No. It is a product of the success that we've had, the ability we've had to earn dollars through this program by changing people's lives, and now to think more broadly about how could we affect more people. And so we're moving to expand our benefit program. That's change. I'm glad I was here on time, not as glad as Katie was, but I'm glad. I worked in the hospital last night until about midnight and was admitted in the emergency room, and it's always eye-opening to me when I'm working as a doctor instead of as an administrator during the week. And I was struck by just the cases I saw last night and their relevance to the work that we're doing. You know, I saw 2 different people at Del Seaton who have advanced colon cancers that were diagnosed with stage 4 disease and should have been screened. Met all the requirements for screening, we just didn't screen them. They just didn't get screened in a timely fashion and presented with bleeding. And that's how we diagnosed them. And then when we work them up, they've got stage 4 metastatic disease, and both of those individuals are going to die soon. We're not going to save them. It's a tragic deal. Super tragic because those are preventable deaths. If I catch your colon cancer when it's a polyp, the GI doctor lops it off and tells you need to come back for a colonoscopy every frequent, you know, and that's it. We quit having the conversation. These people didn't get that opportunity. The system failed them and they will die as a result. That's why we do this. So if you wonder why screening and prevention is important for all of you who've decided to bite off something in the screening prevention bucket, it's not just numbers on a page. It's not just an aggregated spreadsheet with your numerator and your denominator and how many people you managed to get screened. In our safety net in Travis County, I believe we screen colon cancer at a rate of about 35 to 40%. That's great if you're part of the 35 or 40% of people who actually got your colon cancer screening. But it doesn't do much good to you if you're in the 60 to 65% who didn't. And I happen to know 2 people recently who would live in that denominator but not in the numerator. And it sounds like math until you have to stand over them and tell them, I'm sorry, you have stage 4 cancer. Your 5-year survival, if they push you to tell them about it, is probably less than 2 years. It's probably measured in months. So, as we talk about population health, as we talk about your aggregated numbers, and those things are important, and we've got to pay attention to them, understand that the opportunity is in being able to get to everybody. There are real people with real names, just like you, who live behind all of those numbers on all of those spreadsheets. It's not an abstract thing. Every one of us in this room is responsible for creating health in the individuals for whom our organizations are responsible for. That is your job. And I know, by the way, the reason I'm speaking so strongly to you, I'm tired and haven't had enough coffee. But it's also because I need you to really believe that. And the reason you have to really believe that is because you're a change agent. Because it's not just about you embracing that notion. It's about you translating that for your whole organization. For all the people in your organization that aren't in this room today. For all the people who sent you here to hear what's the latest and greatest, how are we going to move through this next DSRIP program, and are waiting for you to come back and talk to them about what we need to do. The program is a great thing. It is not bigger than the people we're trying to care for. It is a means to an end, and the end is better health for the people for whom we care. That was always the end. And that's largely why there's only one of you that I saw who could raise their hand and say, yeah, DSRIP is still run out of the finance department. Because your organization's figured it out. This was never about the finance part at all. You're always going to have money come in and out of your company, and you're always going to need a finance department to manage that. But we're in the business of health. And you figured it out and moved these programs so that they are appropriately administered in your company where you can keep that in mind. But you got to keep that in mind. It's real easy to slip back to just a numbers conversation. I'm probably the least qualified person in my company to be running the DSRIP program, but I run the DSRIP program in my company. Now, luckily, I have really, really smart, talented individuals, some of whom are sitting in the room, who actually manage the program for me, because if it was just up to me, we'd fail miserably and wouldn't have drawn any of our money. Because I can't keep up with all of the stuff that you have to do to satisfy HHSC and CMS and all of that stuff. So why do I run it? Because my job is to make sure that everybody understands at the end of the day, did we improve people's health? If we did, we succeeded. If we did not, we failed. It is as simple as that. If you keep that first and foremost in your thoughts, it will drive everything you do. When you ask yourself about chronic care management, how do we take care of our diabetics? I told this story at a recent retreat we had in my company. Took care of a guy in the hospital, a young guy, 24, has diabetes. And in June of this year, he got admitted to the hospital because he had a diabetic complication called diabetic ketoacidosis. Basically happens when you stop taking your insulin. You stop taking your insulin for some reason, or you don't have enough insulin in you, and you get really sick. Your body cannot survive without insulin. And type 1 diabetics don't make any. So if they stop taking it, they are screwed. They are going to get really sick. They are going to try to die. They are going to end up in a hospital. And so this happened to this guy in June. And the reason why he stopped taking his insulin, which is what happened to him, was because he was feeling sick to his stomach and nauseated. He realized that he wasn't going to be able to keep food down. he thought it would be bad for him to continue to take his insulin, so he just cut himself off. Quit taking his insulin because he wasn't going to eat any food and he didn't want to bottom his sugars out. And then over the next 2 days, he got very sick and ended up in the hospital. And so he gets out of the hospital, goes on about his life until about 10 days ago when he gets very nauseated again. People who have diabetes sometimes have gastroparesis or other reasons why they just feel nauseated. So guess what he did? Stopped taking his insulin again. And very predictably, over 2 days, he got really sick. And then he ended up in the emergency room where we again had to emergently treat him and put him in the ICU. Now, the first one was just unfortunate. The second one was unconscionable. Why did this happen? Because we did not do a good job of making sure that this guy understood his illness. He didn't understand what he should have done, and we had every opportunity to teach him. We didn't do it. And so he did the same thing twice and risked his life twice. And if you want to think about it from the money standpoint, he cost us probably $100,000 twice because we couldn't be bothered to ensure that he understood what he should have done was stay on his long-acting insulin, stop his mealtime insulin, and call his doctor and tell his doctor, hey, doc, I'm sick. I'm not able to keep food down. What should I do with my insulin? So that we could have managed him. But instead, we let him risk his life twice. We've got a long way to go. That's why it matters that we engage in the space of chronic care management. Everybody get a flu shot? All right, I won't ask anybody to raise their hand if they didn't get a flu shot. But I hope most of you got your flu shots. We had a horrible flu season last year. Horrible. One of the worst on record. And we had lots of people in the hospital because of their flu. We had lots of people who had pneumonia because of their flu. And we had young people die because of the flu. So, you know, when we have a measure that is basically saying what's your influenza immunization rate, that's not just to prove that we can keep track of everything on a spreadsheet and make sure everybody gets a shot. People die from flu. Young, healthy people die from flu. Not old people, they do die from flu. Not the very youngest, they do die from flu as well, but we kind of expect that. People on those spectrums of life obviously can't handle viral illness as well as others. But last year, it didn't seem to matter. You could be young and healthy. You got flu, you ended up in the hospital, you ended up dying. That's why we care. Herd immunity matters. You know, it helps for us all to protect each other. We have put that into a plan. And we have said those of us who are working in the space of adult immunizations, the Healthy Texans bundle, we've said, look, we're going to try to make sure that adults get all the immunizations that they need, including the flu shot. Not because we want to earn the money. That's just a byproduct. Now, mind you, when they hand us the money, we'll happily spend it. And we'll happily spend it on taking care of more people. But the reason we want everybody to get the flu shot is nobody has to die of flu. That's the reason. Behavioral health, I saw that up there on Katie's slide. We have horrible, horrible substance abuse problems in Central Texas. I know everybody and their brother has heard about the opiate epidemic, because that's all you can hear about. And it's bad, mind you. I mean, I admitted a person with heroin overdose yesterday. But what I would offer to you, and what I've recently told my team is, and why we have screening questions for it built into some of these bundles, is what's the substance that causes us by far the most problems? Alcohol. Alcohol. So 2 weekends ago when I worked, on one day I saw 8 people with cirrhosis. Of those 8 people with cirrhosis, 7 of them were from ethanol, or from ethanol and hepatitis C. There was only one of them that actually had a different reason for cirrhosis. Everybody else was ethanol or ethanol plus. We have a problem with alcohol. It is exceedingly evident to me as a hospital doctor, and the problem is by the time I see you in the hospital for cirrhosis, I don't have anything to do for you. By the way, half of those cirrhotics are still actively drinking. But they're probably all going to die of liver disease in the next couple of years anyway. So I'll have to tell you that, my wanting to get them to stop drinking doesn't matter a heck of a lot. Other than I can tell them, you're trimming months off your life. By the way, that's because all you have left is months. So if you'd like to have all the months left available for you, you might want to slow it down. But the real problem I have is we're not stopping people from getting there. That's the intervention. The intervention is not to go chase the people who are cirrhotic. We're already at the end for them. We need to help them have good deaths. As brutal as that sounds, that's about what we have to offer those people. What we really ought to be offering our fellow citizens is we're going to ask you whether you use alcohol. And if you say you do, we're going to ask you some more questions to try to ascertain whether you might have a problem with alcohol. We're going to understand your circumstance, and we're going to counsel you. And if we can help you, we will. Because that's the only way we'll get ahead of it. We got to do those things up front. That's all in primary care. That's us. One of the reasons I hang on to this hospital role is because it is a reminder of how much work we all have to do out here. That's why I left the hospital to begin with and came out here. It's because out here is where you can make a difference. By the time I'm seeing you in the hospital, I don't have a heck of a lot to offer you. We are the pointy tip of the spear. If we're going to create, if change is going to be created, it is us. That is the charge I would give you. And you got a bunch of people in your organizations that are seeing patients every day. You got to make sure that they understand that when you go talk to them about making sure that they use the drop-down menu in the EHR that you just added so that you can have discrete data on whether or not we counseled somebody about their alcohol use. You got to be able to sell them on, I'm not just trying to find you something else to do. Because that's what you hear, right? Or that's the way they act. Because they're thinking, I'm trying to take care of this patient, you're giving me something else to do. I'm doing the real work here, you're bothering me. I'm trying to care for people. Well, guess what? We need to understand if we have a systematic problem in screening for alcohol use amongst our patients. The only way we're ever going to know that is if we can aggregate the data. That means we have to create systems that can aggregate the data. That means the people who are actually talking to the patients need to understand that and need to buy into that and recognize it's important. It is important that I ask these questions. It is important that I fill out the drop-down box correctly. It is important that I counsel this patient about their alcohol use. It's important for the patient. It's important for the system. It is not just something I've got to do because they told me to. And what we have to do collectively is make sure that the people who are going to be taking care of the patients understand that. We have to do that. If we convey it wrong to them, they're going to think about it exactly like I just characterized it. We are change agents. You determine the path of your organization in terms of getting them to understand their role in change. So if you take nothing else away from today, it is I want you to not underestimate your personal importance. You individually sitting in the chair, Rachel. All my colleagues out here, you have to personally take responsibility for ensuring that this program creates health for the patients that your organization serves. If you don't own it individually, then who are you expecting to own it? There's no organizational persona. I don't believe in that. I'm sure other people would get up here and argue with me, Mark. Organizations have personalities and cultures. Yeah, I get that. But at the end of the day, organizations are just collections of people, and people are responsible for their part in the organization. So you have to own it yourself. You can't delegate it to your colleagues. You can't ascribe it or attribute it to your boss. You have to own it, or it's not owned, or nobody's doing it. That needs to be your attitude. If I'm not making sure that we're creating health through this vehicle, it isn't going to happen. I'm responsible, because you are. I'm going to conclude my comments there, and I am happy to take a few minutes of questions until Katie runs me off the stage. Yes, ma'am.
The alcohol, but I think the young people is using the marijuana like a drink and soda. So I don't know what you watching in the hospital, or what are you thinking about all this?
Yeah, so it's funny because in the hospital I see all kinds of things. I don't see that many people hospitalized for marijuana use per se. There's a lot of synthetic marijuana out there. That's what they call it, K2 and other things. I've got a guy admitted right now with lung disease because he was smoking K2 and he inflamed his lungs as a result. They're all problems. I would just say that I am struck by the magnitude of alcohol-related health problems compared to the rest of them. So I don't necessarily de-emphasize any other of them. I think all of those substances, illegal or not, have the ability to really wreck somebody's health. But I'm amazed at the number of people that we see whose health problems stem from alcohol use. We had a person brought from the jails recently who got arrested, got put in the jail. They cut the person off from alcohol because they don't give you alcohol when you're in jail. They recognized that this person would likely begin to withdraw, so they put the patient on a regimen to prevent withdrawal. They tapered the patient off in 6 days, and on day 7, the patient had a big seizure and got brought into the emergency room where the patient is floridly withdrawing. And so now we'll have a lengthy hospitalization, hopefully to successfully detoxify this individual from alcohol before they return back to jail and hopefully get help. You know, it is everywhere. It is liver disease, it is withdrawal, it is trauma, you know. So if I go to I'm not a surgeon, I'm an internist, but when we consult on the trauma service and we see these people broken up in car accidents, alcohol, falls, what is the biggest reason people fall down and hurt themselves? It's not scooters, even though you might believe that it's scooters. Scooters may take over. It's falls. It's falls related to alcohol. By far is the reason why people fall and break themselves up. Second to that is deconditioning from old age. But we have a lot more alcohol-related falls. So not to de-emphasize marijuana, it is a problem in and of itself. It doesn't reach the level of magnitude that alcohol does. Other questions? Yes, sir.
Have you in this community seen any incidents related to the vaping that all the really folks of all ages are doing?
So I haven't seen any direct intoxications. So I mean, you know, vaping, some of them have nicotine and other derivatives in there. I've not seen anybody having a problem because of what's in the vaping liquid, the chemical. What I've seen is people with lung problems because they're inhaling something into their lungs that our lungs weren't actually designed to handle. And so we've seen increases in people who have reactive airway disease and other things because they're sucking stuff into their lungs that probably you shouldn't be sucking into your lungs. The notion that because nothing's burning, i.e. burning tobacco or whatever, because you don't have any combustible stuff going into your lungs, it's somehow healthier for your lungs. I think probably in the next 10 to 15 years, there'll be plenty of evidence that begins to demonstrate that taking something and vaporizing it and inhaling it into your lungs in high concentrations every day for days on end is probably not good for you. In 10 to 15 years, we'll probably have the science to prove it. So for everybody who's waiting for the proof before they stop vaping, you'll be the ones that help us demonstrate that it was a bad thing to do. And for everybody who's waiting to try vaping until the evidence is, thank your neighbor who's vaping, as they serve as the population that will demonstrate to us that it's not a smart thing to do. But, you know, again, I've seen people who have lung disease who have not handled vaping well. And I even had a guy who tell me, well, doc, would you rather I be smoking? And what I tell him is, no, I'd rather you not inhale things into your lungs unless I prescribe them to you, is what I would prefer. So you don't make it about me. What I think you should do is breathe air. Don't live in Mexico City. Their air is as bad as smoking, but otherwise, just breathe air and breathe the things I prescribe. So otherwise, if you choose to do things, you can balance whether one's worse than the other. I'm not going to make a choice for you. Yes, ma'am.
First of all, I want to thank you for your really straightforward remarks about what DSRIP means, and I took some notes about taking that back to our organization. But one of the things that I was really struck was, you know, the whole concept of initially DSRIP being a funding source. And, you know, I've been a medical social worker all of my life. So where else have you seen DSRIP move to in an organization? And can you give us any insight as to the persuasive tactics it might take to move DSRIP out of finance?
Yeah, so to me, we have this great opportunity, which Katie didn't realize she was providing it for us, but on her last slide that showed the funding and the decreases in funding and then the abrupt drop off in year 5, that's what I would argue. Do you want to be the chief financial officer who's responsible for this loss of revenue? Because you're going to lose it. So the only question that we're going to ask in year 10, is that year 10 that it goes away, or wait, 9? In the year that it goes away, the only question that we're really going to have to ask is, besides, well, how the hell are we going to get the money? If there is more money, if that money is going to be reallocated, the federal match, or if we're just going to have to deal with local funds, how are we going to deal with the local funds issue? But the real question that all of us should be asking ourselves is, okay, so in the 9 years that we've been doing this, what have we done? Because if all you did was spend the money to provide services during that period of time, but you didn't actually create better infrastructure and a better way of caring for the population, then I would harshly say, and then you can yell at me later when I'm not in the room, call me names. I would say you didn't do anything. It was great for those people while it lasted. But you know, if what you chose to do is build a clinic and run your clinic and provide additional services to a population that really needed it, and when the funding went away, you closed the clinic, well, that was really good during the period of time in which you could keep the clinic open. It really doesn't amount to a hill of shit when you close the clinic. It won't matter to anybody at that point. Those are just services they're not going to receive. So the question is, what have you done with the money? How have you made the system better in a way that it remains sustainable even after the funding goes away? That was always the challenge for this. I never ever thought the money would last forever. And so we've tried to aim towards using the money to build sustainable infrastructure, not to fund operating budgets. That's not what it was about. So what I would tell the chief financial officer, if they really want to hang on to the program, is then how are you going to guide us forward? What have we built? It can't just be about funding. It can't. And so if your organization thinks about it in that framework, they'll realize that DSRIP living out of the funding structure is problematic, because in the funding structure, all you care about is, do I get the money this year? Because I'm trying to balance my budget. That's the wrong question to ask. The right question to ask is, what have we done this year with this money that creates sustainable change for the years to come? That's the question you should be asking. If your finance department is capable of asking that question and acting on it, hell, leave it in the finance department. You got an enlightened finance department. We ought to have them here at the next conference. But probably that lives somewhere else in your organization. For me and my organization, it lives in the clinical part of our organization, because we eventually viewed this as a clinical program. I'll have to say I pushed it there. But certainly in my organization, people understood that that was the reasonable place for it to live. It's tough. Thank you very much. Yep.
Thank you, Mark. It's always a pleasure to hear you speak, and thank you for really honing in on the urgency of the work that's happening in this room. Linda, your question was really prescient. We are going to go for a break right now, but we're going to come back and have an interactive session that really talks about how to boost your change-making abilities personally and in your organizations. So get ready to surf. We are, if you wouldn't mind, I'd really appreciate it if folks could kind of move up to the front of the room. We really want you know, this collaboration to happen up here close by. And also, if you find yourself at a table by yourself, definitely find a way to join with some other people. We're going to have some interactive work happening. So let's come back at about 10:20, and we will get ready for the second part of the morning. Thank you. Hi, everyone. If I could call your attention, if you make your way back to your seats. As we're getting ready for our next speaker, there's a critical thing I forgot to mention, and I imagine you all saw the video camera here in the back with our trusty staff, Central Health videographer Mike McKinnon. We are capturing these videos so you can share them with these sessions, so you can share them with people in your organizations. We're actually live streaming it on video on YouTube, so keep that in mind. But we definitely want other stakeholders that couldn't be here today to have the opportunity to participate with us. What I'd like to do now is introduce our next speaker, and I'm so excited to do it. His name is John Kramer. He is founder and Chief Transformation Catalyst at Radical Insight, Inc., which is a consulting firm based in Stafford, Texas. John helps organizations assess themselves and their environments and improve strategies, structures, and processes. He's an innovator, a creative thinker, and a certified Six Sigma Master Black Belt. So he has 17 years of organizational effectiveness, quality, and process improvement, which I know is all of your all's bailiwick to some extent. And also, he oversaw the DSRIP program for Memorial Hermann Health System in Houston. So he also knows your particular world. John's also spent 14 years in information technology, and along with his process improvement, Lean Six Sigma experience, he's an applied behavioral science researcher and practitioner, certified in psychometric assessment and coaching in Myers-Briggs and Curtin adaptation innovation theory. So a lot of really relevant skills that we have here. I also want to say that I have just had the greatest time working with him in developing this session. And one thing that's not on this list is he is also an accomplished composer and violinist. And when I first talked to John, he said, well, I can't talk for the next couple weeks. I'm heading off to Iraq, where I am doing some musical work with children who have, children who are musicians who have had their musical education and experiences disrupted. So he's also got that. So I'm excited for the next 2 hours talking about change management, and please welcome John Kramer.
Thank you, Katie. Thank you, thank you. Can everyone hear me okay? All right, great. What a great way to start the morning. I was to listen to Katie give the summary update of what's been going on with RHP7 and the changes in the pike coming down the way for DSRIP. By the way, I don't know if any of you ever have experienced this, trying to explain DSRIP to your colleagues that aren't involved with DSRIP or your family members. My wife said, now why are you going to Austin? Because I'm based outside of Houston. Well, I'm going to talk to this great DSRIP group. Yeah, okay, what was that again? Because in her mind, it's the sound that a Band-Aid makes when you rip it off the skin. You know, and then when you try to say delivery system reform incentive program, that doesn't get the juices going either in terms of what in the world is that. We heard Dr. Mark was just amazing, talking about, in fact, one of his quotes, change sucks. Yes, it does, and it can, and it usually does. It doesn't always, but most of the time it does. When Katie mentioned that you all have been meeting for 10 times, there's been 10 events, right? At least. And that the running theme has been change. It made me stop to think, as a change, my whole wheelhouse is spent with managing change, so change management. You know, the traditional view of change management, and by the way, this is your wheelhouse as well, because Dr. Mark Hernandez was absolutely correct. We are all change agents, whether we realize it or not, when we're involved with DSRIP. That somehow change is about maintaining status quo, so you're in this stable current environment, and then there's some sort of change, static, if you will, that then gets us to a new desired state, which will be the new level of operation. and that we tend to view change as episodic, that we are current state, we're stabilized, and then we have to do something in order to get to a new level of operation, and then only maybe moments or weeks or months or years later we have to go through that cycle again. So it's always this period of what some can call episodic type of change. That actually has changed. In fact, that whole view, that assumption that stability equals effectiveness, that to be an effective organization means to be stable and to be able to weather all and to hold down the fort and to be able to deliver your services or your products or whatever your value prop is to the community and to your customers, that in fact that's no longer, if it ever was, applicable. And in fact, in our world, and specific to DSRIP, I would actually go so far as to call it delusional thinking, that stability equals effectiveness. In our world, and not just in DSRIP, but in business outside of healthcare and just in our current day, is that changing is the new effectiveness. To be agile and to have within your organization the capability to not only absorb, but to predict and manage change constantly. That's really those are the capabilities aligned with managing this change as a continuum. So it used to be in change management theories that the way to manage change when change sucks is that you have to deal with resistance, to understand what are the barriers to change that are going to keep people from adopting and embracing what we've got to do, and to design strategies and tactics that are going to help people move away from resistance. I call that the glass is half empty view of change management. Then there's the glass is half full view of change management. There are other change management approaches that say, no. Don't focus on the resistance, focus on the aspirational vision, the future, desired state. Because if you can pour all of your energy and effort into creating this compelling vision, then you are going to either motivate or by swoon or somehow carry people to willingly drop their resistance and the barriers to move toward embracing the future. And then of course you have to have clear steps to do that. So there's a whole series of change management approaches that you can find that focus on creating that. This new way, or relatively new in the development or the evolution of change management, when we talk about agility, is the aspect of adaptability that an organization has. How well can an organization adapt to a changing environment? So when external forces change, such as funding is going away or our funding sources are going to change, we know that's a given, so how do we adapt? That enters or creates a new dynamic in terms of what kind of capabilities are inherent in your organizations to actually do that environmental scan, to be able to identify what are the underlying assumptions that your organizations are going to need to make in order to create and develop the strategies that you're going to need to then, in the downstream, be able to execute. And so what I want to share with you today is putting all that all those broad areas around change management. One thing is very clear, and that is, and it was another thing Dr. Hernandez said, organizations are collections of people. By its very nature, organizations are social entities. Without people, there are no organizations. And when people are involved, you have intellect and emotion. You have flesh and blood involved in your processes, involved in your thinking, involved in your execution. And so what I would like to be able to do is focus a little bit of time on how we can improve your individual effectiveness in the ability to communicate with your stakeholders, to help share and create this compelling story, this narrative, and to help you tone your message, especially given the very vague, ambiguous, and uncertain climate that you all are in. How many of you are involved in technology in any way here? Yeah. Well, there is a term, some of you may have heard it. It's, you know, if you want to keep up with millennials, and I have to, that's a constant effort for me, is to keep up with the terminology. VUCA, how many of you have heard VUCA? V-U-C-A. V-U-C-A, volatile, uncertain, complex, ambiguous. That pretty much describes DSRIP. It's been describing DSRIP since day one. I got involved in DY2 when Memorial Hermann, when our chief revenue officer suddenly realized, or he came to realize, oh my gosh, this is real. Now the work begins. We got to find someone who's going to do it. And I happened to be at the wrong place at the wrong time, so that's how I got. But no, actually, DSRIP, my role at Memorial Hermann for 9 years, I was the director of organization effectiveness. So I had the Lean Six Sigma group under me. I had a Business Innovation Academy, and really try to keep this ambidextrous mix of innovation and experimentation on one hand, and then effectiveness through efficiency and operational efficiency on the other. And very much like what Dr. Hernandez had said, again, he just said so many things that really resonated with me. We started off our strategy, it was a funding strategy. It was a way to, and in fact, all the good work that the 9 teams over the 5 years, while I was overseeing it, we brought in over $203 million for the 9 projects that we had, and they spanned the spectrum of behavioral health and 24-hour nurse hotlines, school health clinics, family practice. It was just palliative care, a lot of programs. But all the money coming in, after it would help to, it would go to pay for the programs, really went to the hospitals to help offset the uncompensated care costs that the hospitals were incurring for the populations, you know, for the uninsured and the low-income uninsured. So anyway, with that, what I would like to do is go ahead and talk about what I call boosting your signal. And what I mean by that is, how can you improve the effectiveness in how you communicate with others and influencing others? And specific to DSRIP, I would say to your stakeholders. I know that in my case, I had many different stakeholders. They were not all on the same page. Being able to, and yet I needed, the one constant was that I needed their help, some level of participation from them. And it really had to do with meeting them halfway, sometimes more than halfway, to really understand how to get them engaged. It was hardly ever easy. It was usually frustrating. Sometimes it was, you know, I'd leave a discussion or a meeting and scratch my head and say, I don't know how to change this. It's not, you know, what's going on. I don't know if any of you feel those frustrations, but certainly now, with the fact that DSRIP has changed yet again, maybe some of your stakeholders, your roster of stakeholders needs upgrading or updating, and now you have new players or new people that you have to deal with. Regardless, you have a story to share, and it's up to you. The onus really is on you to be able to craft the message, to be able to connect and get your involvement with the stakeholders. It's up to them to ultimately decide whether they're going to play ball with you or not. So what we'll do is, there are 4 steps I want to walk you through. This is going to be very interactive. And the first is creating a vision. And for that, now I just want to make sure, I see one table here of 2. Maybe if you can join, there's a group of 3, so maybe one of you can join this table, and then maybe you can join this table over here. If we have threes, that's okay, but really I would like to get as many, because you're all are going to be working for the remainder of my time with you today. You're going to be working in your table team, okay? So if I can just ask you to do that real quick. Thank you. So before we can talk about, well, how can I, what can I do or say to get my stakeholder on the same page? How can I get him or her to see what I'm seeing or why it's so important? You've got to be clear about your message. What is it that you have to say or that they need to know? And so part of this is things in terms of how you have to establish the need for change. Be clear as to why. Dr. Hernandez already gave us a great why. I don't think we need to belabor that point, but certainly sensitizing the organization to pressures for change. And this really means being able to say, hey, we have either it's an emergent need or an ongoing need in the community, or maybe within our organization that needs to be addressed, that we are, and so the most compelling one, again, to go back to it, is our funding source is going to dry up. We are on a timetable. This is not a, an idea. It's a fact of life, unless something unexpected happens. But we know that our timetable for DSRIP funding is going to come to a close. So that's a pressure that we're going to feel, and so that's something that we have to address. Revealing discrepancies between the current and the desired states. So what are we doing now, and where do we need to be? What's happening or not happening? What's getting taken care of or not getting taken care of in our today's environment that needs to change? So when you look at your programs and you ask yourself how they are directly or even indirectly affecting your outcomes, is it as good as it needs to be? Are we okay with the status quo, or does it need to change? So this is where you want to be clear about where we need to be as to where we are. That creates that gap that's going to be part of your story. And then conveying the credible positive expectations for change. This is really important because you have to be able to make sure that where we need to be is something that is in fact attainable. That doesn't mean you have all the answers figured out now or that you know exactly how you're going to do it, but that it is attainable. And so these are things you need to be clear about when you're trying to understand what is the compelling need to change. So the first thing what I want you to do, if you look in your little handouts here, there's a set of handouts on the right. If you can take out the yellow one that says Creating a Vision Part 1, I'm going to ask you to, we're just going to take a few minutes. I want you to first take a moment and work by yourself in silence and identify, just write down a couple of compelling needs for change in your organization that you can think of. And if you can only think of one, that's fine. But then after a minute, I want you all to take turns in your table to share what you wrote. We only want to list them, so consider this a type of brainstorming. You do not need to try to defend or explain, give the long lead up as to why you came to this conclusion, but just go ahead and list. So it could be it could be any of the things that you are, that come to mind. But what we'll do then is move to a group discussion, and I'd like for each table to settle on one key compelling need that you'll use to work on through the rest of the exercise, or through the session. Okay? Are there any questions? Then what I'll do is I'll give you a minute first to just work in silence, start listing things, and after a minute you can then discuss and share amongst your group. All right, now I would ask you to go ahead and take turns around your table and just share what you have written down and what you believe from your list is the top of mind for you in terms of compelling need for change. Can you give me 1 minute? All right, so now if I may ask each group, may I have your attention, please? Sorry, one thing, so as Katie mentioned, my very first career, I was a concert violinist. And so I have a great quote from Leonard Bernstein. He was, of course, a great composer, pianist, conductor. He said, the key to success was to have a great plan and not enough time. So you're going to have a great plan, but you're also not going to have enough time for these things. So I'm going to be cutting you in. I know. Let me make sure. Has each table had a chance to identify one, to settle on one key? I know you have a lot of possibilities there, but as long as which table would like to share what they come up with? Do we have a volunteer table? What key compelling need for change did you all identify or select? Yes.
Are people in need of healthcare? People in need of healthcare.
People in need of healthcare. All right, good. Did anyone else, any other table come up with something different? Yes, over there. Pass that around.
It was kind of ironic because we wrote down, quietly, and I had communication, she had communication, but they were two different types of communication. One was communication within your organization to be more clear about what you're doing and be able to talk to each other. And on this side was getting the word out, communication about what's happening. What is DSRIP? What does that stand for? Who knows about it? Who's involved?
Excellent, excellent. And I saw another microphone over. Yes.
Yeah, I was just going to say, I think it's about moving us from being good to being great. And part of this, I think of DSRIP as sort of like cardio version. If you have an asynchronous heart, we're all doing stuff and there's so many things to do and there's never enough time. And yet, if you have sort of the structure that DSRIP provides, it helps you to get the heartbeat in sync, where it's actually working really well. So.
Excellent, excellent. Those are all great. We have one more? Yes, we'll do one more.
We've got to have a sustainable funding model that supports care all across the healthcare system for the safety net.
All right, so a sustainable funding model. All right, very good, very good. So being able to articulate and to have clear in your mind, and this is really about you right now as an individual, clear in your mind, what is that compelling need? There can be many, and you don't have to, it doesn't mean that choosing one means you neglect the others, but right now focus on one, because if you can go through this process, this 4-step process, through one, to do it once in one particular area, you can then apply this elsewhere. So that one thing, but having the compelling vision or the compelling need is the first step toward creating the vision. There's another step too, and that is being able to construct what does that envisioned future look like. And too often, so for example, the one who said improved health care or health care for all, what was people in need of health care. So now to say, okay, let's realize what that future vision looks like. What do you see people doing? What do you see people saying? How do the people who need the health care, what do you see them doing? Those that are delivering health care, what do you see them doing? How does it work? What does it look like, smell like, taste like, sound like? Getting very, very specific. This is an exercise that I will tell you most of the time I get a collective ugh or groan in the audience or in a team because it's hard work. Oh, John, you know, isn't it enough to say we want to improve? Why do we have to be so specific? Or you'll get pushback. How can we be specific when we don't know? And that's the key thing, is that if you struggle, especially two or more that are discussing about what the vision is, this is a great way to calibrate what the visioning is, because if you are envisioning great health care as being, you know, not having to wait when you go to the clinic, that your 9 o'clock appointment really means 9 o'clock and not 9:30 because 20 other people in the waiting room all have 9 o'clock appointments. Or, you know, that could be one vision. Another is, you know, I don't have to go to the clinic at all. The clinic isn't in my future. The information comes to me in my home or at work or wherever I may need it, in a, maybe through a drone, who knows. So, but it can be much different. So this is a great calibration exercise to get you thinking about what the future needs to look like. That means being very specific and to be able to at least understand what are the key things that are important in this desired state. It needs to be passionate, engaging. It's an engaging statement. This is where I've heard time and time again, this is a business, let's leave the emotion out of this. We're here we're professionals, we're having an intellectual discussion, we're using rational, logic and data to support our decisions, let's leave the emotion at home. I have learned, my experience, you may have a different experience, my experience has been when a person, usually a higher up in a group, says or counsels or admonishes the group to leave the emotion aside, that's a good indication that the decision that will come out of that team is very much emotion driven. It is not driven by fact and rationale. When you are in a situation where you are, again, we are organizations of human beings, and we are talking about what more intimate thing are we talking about than a person's health and well-being. And being able to speak to and recognize the emotional does not mean that we lose all sense of logic and that we simply just are rash, make rash decisions. It means that we acknowledge and recognize the things that may not be said in the room due to, and then it can be a number of reasons, maybe fear, maybe there's other reasons that may get in the way. So being able to excite people, to tell people and to motivate them to make a change, especially if you're going to a stakeholder and say, I need your help. Heretofore, we were able to run this program with what we had. I need your help going forward and in a new way, and this is why. And it can't just be just the facts, because that person, unless that person responds well, but typically they're going to need more. Your members, your community is going to need more. Let me ask you this, how effective do you think a message on to telling, let's say, smoking cessation? I used to be a smoker. I quit in 2005 after many, many years. For years leading up to that, I heard the message, I understood, stop smoking is bad for you. I got that. I smoked anyway. So applying logic, oh, you can get lung cancer, you can die. Yeah, I got that. I still smoked anyway. There was no emotional connection for me that made it real. You could show me a picture of a black lung, yeah, okay, that's gonna get my interest. What did it for me, though, was a personal scare where I thought I was having a heart attack. Turned out it was gas, okay. But It got me to the end. I was also very overweight, just a lot of things. So I was that classic, you know, middle-aged old white guy, just, you know, living life large until it was almost going to kill him. So I needed to be able to make a connection that made it real to me. So in your campaigns, in your awareness, one of you mentioned how to get the word out externally. If you really are serious about improving the health of people, you've got to talk their language and you need to enlist their hearts. You need to do that with your stakeholders too. Okay, I realize now I'm sounding preachy. Let me just, it should feel exciting and compelling. So your visioning about your future needs to be a very emotionally led, but not necessarily emotionally exclusive message about your purpose and about what you're doing. It creates a word picture that is emotionally powerful to members and motivates them to change. So we want to take a moment now to actually, this is where I want you to get emotional. And that doesn't, and we'll leave it to you in terms of what that means. But I want to go into this next exercise. Just one more slide before we get into that. So being able to describe what is the envisioned future and what it looks like and how to make it really exciting and compelling. So again, when we go back to, if we're talking about diabetes management, that terrible story that Dr. Hernandez had talked about with the guy who didn't realize what he was doing to himself by stopping the insulin. Okay, so there's an educational opportunity, but you know, that guy is, I can relate to that guy because I'm also diabetic, and I cringed when I heard that story. And you know, for me, it's not about, I want to be good and I have all these devices now that that tracks everything I do and sends me happy birthday announcements once a year. I mean, it knows everything about me. But that's not why I'm doing it. I want to be able to lead a vibrant life. Okay, I don't want diabetes defining who I am. I want to be able to manage it. But that, you know, for me, it's, you know, so when people come at me and saying, oh, you're a diabetic, or you're pre-diabetic, I hate that term, you're pre-diabetic, because it's like saying, you know, you're pre-terminal, you're pre-death, you're still living, but at some point you're not going to live, you know, and so it's so, to me, it's disempowering, but I'll get off that soapbox. But the point is that you want to be really clear about how to engage people beyond just the outcome, but what it means to them as to why this is so important to them, which means you have to think out of the box and out of the specific box of medical thing. I was 2 weeks ago in Washington, D.C. I was speaking at Kaiser Permanente. They have a beautiful facility called the Center for Total Health Care. I heard an interesting statistic while I was there that, and you may all know this, 80% of the factors, the key factors for healthcare, do not take place in the physician office. They are your social determinants. They are transportation, housing, food security, jobs, the economic, all these things. And what KP has decided to do in the Washington, D.C. area is rather than focusing on one of those things, like food security, they have focused their effort on one zip code and are putting all in. They are putting pouring money into funding housing, transportation, daycare services, really trying to get at the heart of what is critical and impacting the lives of the people within this particular zip code in terms of being able to manage their health care. We know and I was really blown away, and we got to go visit one of the areas, and that was even more interesting and more impactful to see how all those things taken into consideration can ultimately impact the quality of life and the health of the individuals, the community. And so I think we need to be doing more of that. I was listening to what you guys are doing here in this region, and it's really extraordinary. We need to be doing more of that. And the last thing I'll say about that is I spent many years looking at graphs of how of the international, how much, how many dollars are spent in healthcare by the different countries of the world, and then as one factor, and then the outcome being life expectancy. And the United States, way ahead of anyone else, outspends more than any other country in the world in healthcare, and yet our life expectancy is actually not as good as some of the other countries. And it would be interesting to see. I've not seen a graphic, and if you all have, let me know, because I would love to see it, as to what the United States and all the countries spend not only in medical care, but also social together, and then to see how that, what that would look like. So that's my next to do when I have a moment. Okay, getting on to valued outcomes. We talked about the specific performance human outcomes. Clearly, DSRIP, the way it's designed, you can't escape it. Outcomes are what you need to focus on, and honestly, they are what need to be focused on. How you get there is up to you. They can serve as goals. BHAGs. How many of you may have heard of the term BHAG? Big, hairy, audacious goal. And I did not coin that term, and I'm trying to remember where that came from, and now it escapes me. But anyway, clear, tangible, energizing targets that serve as rallying points for action. So if you're going to try to stir the emotions and get people passionate for your change, for your compelling need for change and your vision, then you also want some type of, insanely over the top outcome that is going to animate, inspire, and really just engage people not only through the mind but also through the heart. So what I'd like for you to do now is I want you to go back to your list, and now that you all have settled per table, now that you have your settled on one particular compelling need for change, is I want you to look at an outcome. Identify an outcome. We're still on the yellow sheet. We're on the bottom of the yellow sheet where it says bold and valued outcomes. And I want you to just identify. You can do this as a table discussion, but I'm not looking for quantity, but you can brainstorm and then pick one. Do not put pressure on yourself that, oh my God, it has to be the perfect one or else we're screwed. No, no, no. Just pick one, but one that you all feel good about working on or spending a little, because we're going to carry this forward into another activity. So take a moment. I'll give you 2 minutes to discuss and come up with an outcome that fits your need, okay? Are you timing? Okay, very good. So let me ask you to wind it up, please. And we'll move on. So by now you should have a compelling need, and you should have an outcome, a bold, valued outcome to play with, all right? Need and outcome. So now we're going to move to a purpose statement, and I want to actually show you a model of how to write the perfect purpose statement. What you want to do, a purpose statement, similar to there's visioning. How many of you may have gone in your organizations, gone through a visioning process, maybe with your strategic planning, and maybe with SWOT analysis, and then, some things to try to understand, okay, what's our vision, what's our mission, so vision and mission statements. So now I'm talking about a purpose statement. Is that the same thing? Is that different? The purpose statement for us right now is about why we exist. Why are you here? And what are you doing with DSRIP? What is it you're trying to do? And so there is a format that I'm going to want you to follow, and you all are going to take some time to craft your own purpose statement. I'm going to walk you through this process. With any process, by the way, practice makes perfect. So it may feel a little strange or awkward at first to try to stretch these muscles, but it does get easier over time. You want to craft a concise and compelling purpose statement as something positive you are going to start or create, no more than 9 words. Now, does it have to be 9 words, John? What if it's 10 or 11 or 12? Okay, go for 9 or fewer. If it's 20 or 25, which typically is where that's my sweet spot, you got to axe it down, you got to edit. But I want you to look at the format, use the format blank, so we, our team, our department or organization, our DSRIP program exists to, and then choose a verb, and then choose an object, whom or what, and then the outcome, so what, or the outcome that you're trying to do. So we exist to do something, to affect something or someone, to achieve an outcome. Let me give you, these are, I will be honest, they're not the greatest examples, but they're real examples from other teams. We exist to invent here, let me actually go back here. This is from a team that it's basically a PMO office, the team of project managers. We exist to invent a new form of organizing by pondering, practicing, playing, and pouncing together. Okay, they needed that extra punch. They liked the alliteration of all the P words, but that was their investment. It got them charged and going. They loved it. And that's really the idea. Whether you love it or not, it doesn't really matter. They loved it. What you want to make sure, though, is that your purpose statement is not only something you're in love with, but will also resonate with who needs to hear it, whether it's others internal in your organization, other stakeholders, customers. Another example of one is we want to create opportunities for everyone, including ourselves, to become what they are capable of becoming. So very, aspirational, expansive in terms of where they want. Notice these are not granular, specific things, okay? These are not charters or mission statements that you see that usually are a paragraph or 2 multi-sentence. It's one short thing that really just gets to the heart of what they're trying to do. It does not get burdened down with details or strategies or plans or measures, does it? So there's one other, now sometimes, frankly, it may be hard to try to talk about what is it we're trying to do. Sometimes it might be easier to think of what are some things we are trying to stop doing. So there is, in fact, a negative form of this where same format, but it goes as our team, department, org exists to stop, and then you put a verb and whatever. That may get you to think about different ways. Now, I left Memorial Hermann a year ago last October. I started my own company. I'm still this is the first year. I just opened even unofficially in January, so I haven't even done the big launch yet. If you try to go to my website, it says under construction, so it's still very new. But I walk the walk. I needed to see, okay, what is it that I'm trying to do at my age, where I'm close to, not quite yet, at retirement, but you know, what is it that I want to do in the last decade for me that's going to be purposeful, and not only for me to provide meaning, but will also be of value to the world. I just don't want to do things just to keep me occupied. So I played with this, and I came up with a positive form as well as a negative form for my own company in terms of where I want to play. And so as an example, this isn't to try to, maybe it sounds like a little self-promotion. That's not the intent. But what I did for the positive form is I said, Radical Insight, Inc. exists to unleash the internal wisdom and power of organizations to create, adapt, and thrive. So I want to work with organizations who want to build things, whether it's building new products and services or building themselves. I want to help them to find ways to adapt to the changing environment and to prosper. I also, and so at first I thought, okay, well, you know, that's not too bad. That pretty much reflects what I'm thinking about. What would it look like if I put it in the negative? So I said this, Radical Insight, Inc. exists to stop the limiting thinking that stifles innovation and human connection in organizations. Because I realize that sometimes it's our own selves that get in the way. Our thinking may be too small or not be open enough to be sensitive enough to listen or see other ideas that others may have. And as a result, we're blind to it. And then we end up becoming impoverished by not having all the available ideas to make decisions. So those are just two personal examples I want to share with you that I've gone through this exercise. I continue to go through it and we'll refine. So now what I want to do is ask you to take a moment. We're going to give you a couple of moments to go through your, as a table, and to create your purpose statement. You can either do it in the positive form or the negative form. Let me just, a few things just because, just as a guideline though. I've spent a lot of years in quality and process improvement. The mindset is we can always do it better, we can always do it better, never be satisfied with it. And there was also an expectation to always come up with really great ideas. You didn't want to be the guy or the woman who came up with the really nutty ideas that no one would consider. So what happens is we go through this elaborate self-editing process when we brainstorm where we don't want to appear stupid. I'm asking you, and this is maybe a stretch for most traditional operations, to think out of the box. I'm asking you to be very exuberant in your language and to use emotionally charged words in your purpose statement and to think big. And the most effective way to do this as a table is to just throw things out. Don't try to sit there and quietly come up with the perfect statement and then offer it to the table and hope that no one laughs at you. I would rather that you just work and just throw things out, throw, so that you have a million different things to at each placeholder, and then spend the last moments to just configure almost like Mad Libs. Do you even remember Mad Libs? You know, we just kind of throw out words and then arrange and to make sense. But that's the guideline. I'm not going to tell you what to do. That's just my 2 cents. You will have 5 minutes total to do this, and then I will ask for volunteers, tables to read their purpose statements to the others, and the others will be able to gauge, they'll give you their reactions, and you can gauge how much of an impact they have. All right, that's no pressure, is it? All right, so any questions? All right, and so Patty, if you wouldn't mind, 5 minutes. Thank you. You have 1 minute left. So. All right, so if I may ask for your attention now. How many of you feel you needed more time? Yeah, a lot, several of you, quite a few. So this is something, again, this is just designed to get your feet wet with something. Which table would like to share their purpose statement to the crowd? Let's test it out, get some feedback. Okay. Could I have everyone's attention, please? Go ahead and stand.
Thanks, Kit. We exist to cultivate patients' engagement to improve social, emotional, mental, and physical health.
All right, great. All right, who else would like to share what they've come up with at their table? All right, over here. Oh, I'm sorry. Okay, let's go over here. This one.
Integral care exists to affect the root causes of health and illness so that clients can lead vibrant lives.
All right, very good, very good. And one more.
We exist to disrupt inefficient, expensive healthcare systems to better create health and wellness in our community for the populations we serve.
Wow, okay, excellent. Just a question to you guys. How did you find this exercise? Was it, this activity, was it difficult? Was it, what was the experience like? Just, does anyone want to share what it was like for them? I saw some heads nodding. How many found, who would like to just share? Okay, now we've clammed up. Okay, not a problem. This isn't, if you've not done this before, you know, it might feel a little awkward at first, but this actually, the process is actually, I feel, more beneficial to a group than the outcome, because you're all having a chance to really consolidate and calibrate, get on the same page in terms of what your purpose is, and that can be very clarifying, and you'll either know if you're all on the same page or not, that's for sure. Okay, so let's move on. How many of you have heard of elevator pitch? The elevator pitch, yeah. So there are going to be times where, most often, you are not going to have the luxury of time to be able to, with a 15-slide PowerPoint deck, try to talk to people and explain the ins and outs of DSRIP and what you do and why it's so important and how it helps. You've got to be able to really be very, very concise. And concise doesn't necessarily just mean less. It means that it has to be powerful in making the message. So there is a 4-sentence format for elevator pitches. There may be other formats, but this is the one that I'm used to, and it works really well. And basically, now it says what our project is about. It could be what our program is about, but basically the first sentence is going to be your purpose statement. So you already have the first sentence of your 4-sentence elevator pitch already constructed. If you follow the format here for an elevator pitch, your second sentence is going to basically say why it is important to do. That may be covered to some degree in your purpose statement, your opening statement, but you can go into a little bit more there. Again, just one sentence. The third sentence, what success will look like. And then the fourth sentence is what we need from you. Now, the way this works and the beauty of this elevator pitch, once you develop it, the first 3 sentences will rarely change, if ever. The fourth sentence is mutable, and that's going to change depending on who you're talking to. If it's a certain stakeholder, because what you may need from that person, because it's all about what we need from you, is going to change depending on who you're talking to, right? So if you can get your first 3 sentences written or crafted for your program, you can easily memorize that, and now you only need to tailor that fourth that provides the bridge to the particular stakeholder, or it could be, you know, whether the stakeholder is an internal business partner, whether it's an individual, a patient, or maybe a community partner, another DSRIP provider that you're working with. It doesn't matter. It works for all that. So I'm going to give you an example of one, again, coming out of a hospital system. I realize this example is hospital-centric. It's around ED throughput. Any time you have an emergency room, you're going to have patient throughput improvement issue. You know, there's whole national conferences devoted around ED throughput. It's just a perennial issue. But let me just read what this says. So we are reducing the time it takes to treat and release patients in the ED so that every patient gets the right care they need at the right time they need it. Delays can negatively impact the patient, leading to longer stays and possibly adverse outcomes and complications. Providing the right care at the right time would increase our capacity to serve twice as many patients who enter our ED seeking treatment and other services. To achieve this goal, we need your help by supporting our data collection activities and providing access to some of your team resources. Now, this was tailored toward an executive who oversaw an area that delivered reports, and we needed their help for additional reports as well as resources. So that's one example. There are many others, but what we'll do for the sake of time, I was going to allow you all a chance to try to work on the rest of your elevator pitch right now, but I think it's enough for you to understand just the format, the structure of the elevator pitch. Let me just ask, because we're going to leave this and move on to something different, but before I do, are there any questions regarding the elevator pitch or the construction or getting to this point at this time? Okay. All right. So we will now move on to knowing your stakeholders. And this is really in terms of overcoming the resistance. We need to understand, in fact, I'm going to go ahead and ask you to pull out the white page. It's actually the legal size, so it's folded. This is a stakeholder matrix. What would a DSRIP meeting be without a spreadsheet? So I wanted to make sure we honored that tradition. So in terms of overcoming resistance, empathy and support, again, going back to Dr. Hernandez, he talked about walking in others' steps, in shoes. For us to be able to understand whether it's an individual's health that we're talking, whether it's a pregnant mom, a mom-to-be, or a person suffering with some sort of chronic health issue, or whether it's children getting access to dental care, whatever the need is, we have to be able to understand, and more specifically, in the stakeholder, if you're talking to a finance person or an IT person, or the chief medical officer, or any other functional lead of the organization, to understand from their position what life looks like and what their day-to-day is, as well as to understand what DSRIP looks like to them. Once you're able to probe and be able to understand that, it's going to put you in a much better position to be able to tailor your messaging and communication so that they can understand what you're talking about. Communication, big important. Sometimes, how many of you may have heard, well, I don't, in where I was working, I heard a lot, it's better to over-communicate than to under-communicate. I don't know about that, because what happens when you over-communicate is people will turn you, it's almost like, crying wolf. The emails you start to gloss over, they disappear, you don't see them anymore, you just hit delete. Toward the last year I was there, I actually set up a little email Outlook rule, so if it comes from this person, it immediately goes into a box I would never have to look at. I had a nice pristine inbox and all this unread stuff that would go there. That made me very popular, but it kept me sane. And people do, these are coping skills to just get you through the day. So it's not about how often you communicate, it's how effectively and by what means. And of course, I know that Katie told me there are several of you that are project managers and you've gone through your PMI. Clearly, it's a communication plan is vital. We're not going to talk about a communication plan, but that's central. But once you get beyond the mechanisms and the frequency and the delivery channels, it's really about the message. Is you really want to understand what is the content that I should be sharing and delivering to the stakeholders for the purposes that I need from them, okay, to support me so that we can be successful. Participation and involvement. This is not something that you do off on your own in some sort of conference room and then you sort of spring it on your stakeholders. It's something you really need to reach out and find out ways to do that. And we're going to talk about that because that may sound good. You may say, hey, John, great, but you don't know who I'm dealing with. And this guy is a high mucky muck and I'm just a spit in the bucket. So how am I going to, leverage or handle that distance with status or with, organizational barriers or structures? So we're going to talk a little bit about that as well. So first is let's identify who the stakeholders are. And one good way, and I'm sure you already know, who your stakeholders are. I don't know if you know all of them, and you may, but given what I understood in discussions with Katie, I know, well, let's just test this. How many of you, for DSRIP going forward, are going to have to work with new stakeholders that you haven't had to work with before? Are any of you into that camp? Okay, at least one. How many of you are basically working with the same old crew that you've been working with through the first waiver? One, okay. How many of you, so where does that leave the rest of you? How many of you have stakeholders? Let's start with that. Okay, you all have stakeholders. And raise your hand if you would like to be able to increase the effectiveness of your communication with your stakeholders. Okay. Okay. So okay. Katie asked, could we talk a little bit about what we mean by stakeholders? And so let me, in terms of identifying who they are. So let's just start with this short list. Who has interest in the changes or in DSRIP? You can just say, who has interest in the DSRIP program? And that can be staff groups, unions, department managers, top-level executives, it can be anyone. But who would have an interest in in the DSRIP program? Who can thwart, support, or block these changes? So who are and the who can either be, typically it's a person, but it could also be a department or an organization, so it doesn't always have to be one individual person. You might have, so a stakeholder could be a certain individual within an organization. It could be a type of DSRIP provider, or maybe it's managed Medicaid, could be a stakeholder. The patients can be stakeholders. Who are the key external stakeholders? We just talked about that. Regulatory agencies, suppliers, community. HHSC for sure is a stakeholder. They're driving the train, and as well as other agencies that you're having to provide information or receive information from. Who stands to gain or lose from these changes? So even if and especially those that may not be actively involved in DSRIP, but may stand to gain or lose, you want to just understand who they are, because they are, it's important to understand, especially if there's if they stand to lose, what that might precipitate in terms of either resistance or blocking or interference, as well as those that can gain, how they can help you in terms of what you need to do. Are we clearer about our understanding of stakeholders? So it's a wide swath. So what I'd like for you to do is just take a moment, and I only want you to focus on, let me just show you just focus here on identifying, and you don't have to fill out all of them. You may have 10 or more stakeholders. for purposes of today, just identify maybe 4, okay? 3 or 4. I would pick the ones that you are most interested in wanting to improve your effectiveness in communicating. So don't pick the easy ones, the ones that already advocate for you and just love hearing more about, you know, every time you have an update. Pick the ones that you really have to work on in terms of wanting to get where you need their help. And then I want you to do focus on these 2 columns here. Don't worry about the others on the right. I want you to pick a number from 1 to 5 and list their current level of support. So where are they right now as where you would assess their level of support? Are they strongly disagreeing against what you're doing? Are they moderate? Are they neutral? Are they supportive? Are they very supportive? And then take a stock as to where you believe they need to be for you to be successful. It would be great and wonderful if all your stakeholders could be wildly enthusiastic and in love with what you're doing and are going to be your advocates on the ground and just make things happen. But that may not be necessary for you to be successful. If you have someone that currently, or an organization that is currently more than moderately in disagreement with what you're doing or what you're asking from them, getting them to neutral maybe is the best you can get, but getting them to neutral will mean that they're not actively working against you. So take a moment with the 3 or 4 stakeholders that you list and just write them down and then pick a number 1 through 5 on their current level of support and then a number from 1 to 5 on where you believe they need to be to help you with what you're doing, okay? We're going to take 2 minutes to do that and work individually at this point. And now I would like to go ahead and, if you haven't finished all 4, how many of you have at least finished 1 stakeholder? You've identified 1 stakeholder? Great. All right, so now what I want you to do is look on the next 2 columns, one that says concerns and issues and the other is wins. Identify, based on what you know today, what is the pain point, the issue, or the concern that the stakeholder has about supporting your effort. If you don't know, just put don't know. You know, you'll find that out later. And then identify, if you can, what would be a win to that stakeholder for supporting the effort? What's in it for them or their area that you can identify that's going to be important to them to move forward in providing support? So just do that on 1 or 2. We'll take a minute for that. All right, let me ask you, raise your hand. I won't ask you to divulge who or what or whatever, but who all listed as stakeholder and gave them a current level of support of either a 1 or a 2? Do we have at least, and I won't ask you to talk about it, I'm just curious how many of you are facing a stakeholder you need that is heretofore not supportive of your program? How many of you had identified a stakeholder that's neutral? Okay. And how many of you had identified a stakeholder that's either a 4 or a 5, moderately or strongly supportive of what you do? Okay, more than that. So who raised their hand when they said they had a 1 or a 2? Okay. Can I ask where do you feel they need to be? Again, I'm not asking for the specifics, but for that person, if they were at a 5 or at a 4, where do they need to be to help you? They need to be at a 4. Okay. All right. Very good. And for those that said neutral, is it necessary for them to move out of neutral? Do they need to be either moderately or strongly supportive? Yes? Okay. All right. So what you're doing here is you're trying to use this tool to help you understand how far is the distance from where they are now to where they need to be. So it's not about, again, trying to win them over so that they have the same level of passion and interest. You're being very strategic about how you want these, where you need these relationships to be with these stakeholders. Okay, so with that, now that so let's just review very quickly. We had gone from creating the vision, focusing on our purpose, and on then understanding what kind of stakeholders we have and where they are. Now we need to develop strategies on how we're going to develop this political power. And one is assessing your own personal power. Each of you has, by virtue of your position, you have a certain amount of authority that goes along with your position at work. But in addition, you have personal sources of power as well. And I want to talk about, there are 3 of them here that are really important. One is knowledge. Some of you may be, in fact, have expert knowledge in what you do, and you are recognized by others as being an expert in your field. And that gives you a lot of credibility, a lot of power, because how many of you know of someone who said, wow, when this person speaks, I listen? There's even a commercial, an investment commercial, where I remember an old one where in a crowded restaurant, everyone's eating, and someone says, yes, when I talked with, mentions the person's name, suddenly everyone goes quiet. It's like, oh, what did he say? So for those people who command respect and command a lot of power because they have built a reputation, they have expertise that's known, there's a lot of street cred associated with it, that carries a lot of weight. So the knowledge that you have is very important and can be used as part of your power set, if you will. Now, what happens if maybe you're not that well established in your career or in your position? You haven't been there that long to be able to develop years of expertise. Does that mean you're SOL? No, not at all, because there are other things that you may not be viewed as the expert in the room if there is a towering expert that everyone else knows. You can look at personality. Personality, charisma, reputation, professional credibility. I'm sure all of you know people who you just like to be around them. They just make you smile. If they ask you to do something, you will say sure, or hey, Can you help me? I want you to get you involved. And the reason you do it is maybe less about the intellectual reason and the logic as to what they're trying to do. It's just because they're fun to be around. And it's going to be, you know, you just sort of get that feeling about being around them. Well, that's the personality and the charisma. And if you're one of those that has that, that's something that can be very powerful in how you get things done. It may sound cheesy, but it's not at all. It actually is something you need to recognize. And if you don't feel you possess it, you may know others who possess that. And then another personal power, source of personal power, is others' support. There are people who, okay, maybe they're not the leading expert or perceived as they may think they're the leading expert, but if they're not perceived as the leading expert, and maybe they're not perceived as having the charisma of a, you know, the personality of a that is going to carry people, they may in fact be a great networker, and they may know, they may have in their, I was going to say in their Rolodex, but that's really old school, but they may have in their contact list, they may know people that they can reach out to who are big fish in other areas. And so it's others' support that they can count on and reach out to that gives them power. So I want you to take a moment and look at what color are we on now? We're on the green, I believe. Yes, the green page, personal power self-assessment. And just focus on the top half. I just want you to rate yourself on these 3 different sources of personal power, where you believe, this is just how you perceive yourself in the area of knowledge, personality, and other support. And let's be specific in the world of DSRIP. So your knowledge of all things DSRIP and how you function. You can be fluent in Swedish, which would make you an expert, because I don't speak a word of Swedish, but that's irrelevant to DSRIP. So in the world of DSRIP, knowledge, and then your personality, and then others' support. Okay, just take a moment and do a self-assessment. You do not, it's voluntary if you wish to self-disclose to others. That's up to you. If you're bold enough to do that, it would be interesting if they concur and provide you, say, yep, you have personality, or you think you have personality? Really? Okay. But I want you, but you don't have to do that. I'm not going to ask you to do that. But do get some clarity on where you think you are at just those, the top half. Let's take a moment. We'll get there. All right. So now that you've done a little bit, how many of you were surprised at how you assessed yourself? Any ahas? Any, oh, wow. No? Okay, good. You are already more self-aware than most people. Each of the, depending on where your strengths lie, there are different influencing strategies that you can employ. And I'll be discussing them in just a moment. But the one, when you have, if knowledge is a strong suit for you, playing it straight is going to be a strategy you'll consider. What does that mean? I'll get into that in a moment. If you have personality, going around the formal system, doesn't that sound subversive? Wow. That might be something that you would be able to use and get away with. And other support, using social networks as part of your thing. So let's, at this point, what I want you to do is finish the second half of the assessment. And actually, you know what? Hold that thought. I'm going to get back to that because I want to talk about what the strategies are, and then you'll be able to identify which strategy you might want to incorporate. So hold on to that. Playing it straight. I don't know if you are Star Trek fans. Yeah, I was, okay. Mr. Spock. Everything was about logic. So if you are the knowledge person, if people recognize you as the expert, you can afford to play it straight in the sense that you can just simply say, okay, here's the facts. Here's the fact of life. Funding's gonna come to an end. We gotta do X, Y, and Z. And depending on how you're perceived, people say, well, you know, if John said it, it has to be true. He knows all this stuff. He's recognized, you know, we consider him an expert, and if this is what he thinks we need to do, then we're gonna do it. And that straightforward delivery, and you know, you can go in with a presentation or a report, have a sit-down conversation with your stakeholders, whether it's other leaders in the organization or your peers or to community groups. Again, if this is how you're perceived, it may not need to be anything more than simply here are the facts and here's what we propose, and that would be an effective way of influencing and communicating with your stakeholders. Now, what you also need to keep in mind, you've already done your homework, and if you haven't, this is the time in your initial conversations with the stakeholders, before you say, here's what we're gonna do, is to really validate and confirm what are your issues and concerns, and how will this be a win for you. So if you're not clear about, you know, that empathy about really understanding their point of view, you want to get clarity on that. But the approach with this is that you're going to determine the needs of the stakeholders. You will present information. This is about data, and empirical data works really well about how the changes can benefit them. The basic premise is information and knowledge can persuade people about the need and direction for change. This is the time where you could say, it's not really about the emotion. I don't need to get your heart all pounding and passionate, because the sheer logic of the data should be sufficient to be able to say, okay, I'm with you. I'll support you. Success of this strategy relies heavily on the change agent's knowledge base. That means you as the change agent. If you're presenting this, it's your credibility, how you are perceived. And again, if this is your strong suit, this is a very effective strategy. Must have the expertise and information to persuade that these changes are a logical way to meet their needs. So if you can connect the dots for them in a logical way, you're good, okay? Now, let's say though you're not the knowledge person, and you know, let's say you're talking to a chief whatever, chief medical officer, a chief executive officer, a chief information officer, or you're talking to a peer. You need to get their support. Maybe you need IT. I'm going to pick on IT for a little bit because I used to be part of their organization, to get a report. And they have 10 gajillion of other high priority requests in their queue from other areas of the organization. And your request that is so near and dear to you in DSRIP is just at the bottom, and they will get to it in 8 months. Well, you don't have 8 months because you need this report for, you know, to report up to HHSC or whatever in 3 months. What to do? Well, you could spend the rest of those 3 months trying to change the corporate, you know, in terms of running things up the flagpole to try to get the priority bumped up. And that may or may not work. But if by doing that, playing it straight in terms of following the processes, you can say, well, you know, I gave it the college try, but I followed, you know, this was the response, and it's the best I can do. Oh well. But that may not be good enough in terms of how it impacts your program. So going around the formal system, I know that this might sound really, well, you know what, it is subversive, there's no way around it, but it can be effective. And there are times when going around the system makes absolute sense. I'm sitting here with Patty as the compliance risk. I'd be interested, she's smiling now, but very uncomfortably. So I think, you know, it's like, oh God, what's John gonna say now? And what is he advocating? You know, mayhem and chaos and anarchy, no. But let me say that this can be used and very judiciously and not all the time, so I'll throw those caveats out. When existing organizational arrangements can be roadblocks to change, working around barriers may be more expedient and effective than trying to remove them. So if you find that and so now this is expediency, and sometimes, and this may take different ways. I will just say this, people who are logic-oriented and fact-oriented are not at all going to use this type of strategy, and they don't need to, and if they tried to do it, it would blow up in their face. Those that can pull off this type of strategy are those that have some element of personality, and it doesn't mean that they have to be, you know, this bigger than life personality, but they have to have a certain it about them where people are going to say, okay, you're asking me to not follow the formal process. We're going to kind of ask for, you know, do something and ask for forgiveness later than for permission up front. How many of you have heard something like that? Better to ask for forgiveness later than, okay. And if you are a Trekkie like I was for so many years, Captain James T. Kirk didn't always go by the book and was always at odds with the Federation because he was finding ways to go around. Well-intentioned. It usually pays off, but it can also backfire. And one of the things that you want to be aware of is that this can be easily abused. So this is really playing with fire, because you may be successful in getting, so for example, you may find a way to get to the CIO rather than working with your peer and do an in-run to be able to get your little report request moved up the line ahead of others. Okay, and you may think, yes, okay, I did something gutsy, but you know, I got my report done. Well, good for you. But what you may not be aware of, and this is where it's on you, is by pushing everything else down in order to satisfy your request, you may have created a ripple in terms of other things that, quite frankly, were higher priority. So you want to be careful how you use this, but don't just simply cross this off your list as something you may not want to do. It can be very effective. And then finally, using social networks. This is where if you are very familiar with or know of other groups that you can reach out to, try to understand and form alliances and coalitions with other powerful groups, so whether it's your provider partners or other areas, and help others move and champion for you. Deal directly with the key decision makers, so you can go to presidents of associations. Or I did a lot of work with the Fort Bend, so there was a 9-county region, part of RHP3, but I live in Fort Bend County, and so that's where things that go on in Fort Bend County affect me and my family in a very direct, personal way. So I was always involved with the stakeholder forums for the district providers just for that one county, and we were able to collaborate and do a lot of things just because we were meeting. And so right now, I just want you to take a moment and go back to the second part of your personal self-assessment, and based on your understanding now of the different power strategies, just make a mental note as to which ones you might consider using. You're not committing to anything, you're just, which ones resonate with you, and which ones may you simply just say, nope, never. Just take a moment. And what you may want to consider then is to finish off these, we won't do it now, but I do want to just explain, when you go back to the stakeholder matrix, the final column, the influence strategy, is now that you know, here's stakeholder A, currently moderately against this program. I need this person, or let's just, is neutral. I need this person to be at least a 4. So here's perceived issues or wins, and then here's an influence strategy I will need to take or consider when approaching that person or group, so that I can be as powerful as possible and as effective as as effective as possible in influencing them. Okay. So at this point, we're wrapping things up. I'd like for you to take a moment to reflect on what was discussed throughout our time this morning, and I'd like for you to just write down, capture just silently some insights that have come to you. What was something interesting that you found interesting or useful? And just take 1 minute to do that, and then pair and share. So pair up with someone next to you and just have a quick discussion. Just share what you found interesting or useful. And we'll move on to one final closeout. Perfect. Just one last thing to do. All right. Would anyone like to share one thing you found interesting or useful for the group, what you shared at the table? Do we have any volunteers? Anyone at all? Oh, over here.
We are actually just starting to talk about more strategic planning. We're at Austin Public Health, and we're starting to talk more about strategic planning, especially as we go into DYs 9 and 10, and talk about what is our story going to be as the funding runs out. And so creating this vision exercise, I thought is very useful for us, and something that I think we'll probably explore more.
Great, thank you. Any other thoughts? All right, we're going to move, oh yes, over here.
I really enjoyed this. I thought it was really good and needed and helpful. I think the aha some of us were talking about was really understanding your stakeholders and what are their stakes, and looking at what is the win from their point of view. As we started writing those down, it was wins from our point of view and flipping that around and taking a look from there. So that was helpful. Thank you.
Ah, great. And you're going to find your plans will explode in a good way when you're able to make those points. Excellent. So the very last thing I want to ask you to do is to look at the pink sheet. This is a Boost Your Signal 1730 action plan. And I just, at this point, just want you to take a few minutes. There are 4 questions I want you to now, I'm inviting you to do this. You don't have to do this. I'm not going to check to see. Katie may or may check to see, but I'm not going to check to see. What's the goal that you want to accomplish in the next 30 days? And it may be as simple as, I want to be able to meet with this stakeholder and turn them around. You know, I want to get that stakeholder support. What one action can I do immediately to boost my signal? What one action can I do in the next 7 days? And then what one action can I do or will I do in the next 30 days to boost my signal? So you know, if you don't fill it out right now, that's fine, but this is your opportunity to set down some goals. I would also invite you at the bottom, there's a commitment pledge. So sign your name and date it, that this is the pledge you make to yourself, and then buddy up with someone, doesn't have to be at your table, it could be with anyone in the room, not me, that will be your commitment accountability partner and will help you stay accountable. And the two of you can powwow for a few minutes on how you're going to hold each other accountable, and then invite that person to sign so that you have this as a daily reminder for yourself in terms of the plan that you have committed to, and that you have someone that's going to help you hold yourself accountable. So I will ask you to, and you may take a crack at it right now while it's still fresh in your mind. You may have a chance later throughout the day, because I know there's going to be, there'll be a breakout later, but there may be other things you want to take away from today that you may want to include. With that, are there any questions from today? Any? All right. And with that, I just want to thank you, and it was really a lot of fun for me. Thank you.
Thank you so much, John, and thank you for all of your work and participation in all of this. I know for me, all of these ideas that John just kind of walked us through is kind of just scratching the surface. So there's a lot more work and thinking that I hope y'all will take advantage of. All of our materials, all of John's materials, slides, handouts, tools, they are available at our RHP7 website, texasrhp7.org. Go to the stakeholder events section. They will all be there. You're free to use them, take them back, use them with your teams. And I definitely hope that this was useful in thinking about where are we going next and how are we going to make that change. Right now it's time for lunch, and I don't want to hold us up from that any longer. We have a buffet. It is going to be out in the back of the room. You can go out these doors, then please walk around and return. We'll eat in here. And I, of course, walked up here without my phone, so I'm not exactly sure what time it is. But it's 12:05. Okay, so we'll have about an hour for lunch. When we come back from lunch, we're going to have a panel of DSRIP providers who will be discussing what their experience in DY7 has been like and what plans are for DY8. So that'll also be in this room. And so definitely take a look at the website for materials. Take a look at in your folders. We've got some more summary information about RHP7, and enjoy your lunch. Oh, I'm sorry, one more thing. If you are speaking on the panel, if you would gather around here at this part of the stage about 10 minutes before 1, we would appreciate it. We'll get set up. Thank you. Enjoy your lunch.
Carol Saucedo, and I'm proud to be part of the RHP7 anchor team. I hope the lunch hour provided an opportunity for everyone to reconnect with their colleagues across the region who are all trying to figure out the new DSRIP and how best to serve Medicaid low-income and uninsured populations. I'm also glad that everyone decided to stay inside and out of the cold. Now I'd like to introduce to you our DSRIP provider panel, moderated by Mike Gieslin, President and CEO of Central Health. Let's see if that works. You may remember these faces from the last time RHP7 stakeholders came together just 7 short months ago, prior to HHSC approving updated RHP plans, and 6 months into DY7 at that point. At that time, providers defined their systems and goals and presented their proposed outcomes measures to stakeholders. So here we are at the start of DY8, and we've asked them to come back and give you an update of their activities, how DY7 went, their progress and challenges and successes. It's now my pleasure to introduce our panelists, some of the hardest working and DSRIP smartest leaders I know. On the far end, we have Richard Waite, Grants Program Manager for Austin Public Health. Next, I think, yes.
It's okay to clap, yeah.
There's a big fan club here for Richard from the city, I could tell, from the registration. Next to Richard is Lydia Long. Lydia is the DSRIP Program Manager for Dell Seton Medical Center at UT and for Dell Children's Medical Center. Next to Lydia, we have Kim Makiagi, Director of Practice Management, 1115 Waiver Projects for Integral Care. Next, we have Ann Berghammer Miller, Director of Health Information Management for Central Texas Medical Center in San Marcos. And then we have Barbara Adams. Barbara is the Service Delivery Operations Manager for the Community Care Collaborative. Our last DSRIP provider is Megan Nagoski. She is the 1115 Medicaid Waiver Director for Bluebonnet Trails Community Services. Thank you, everyone, for your hard work and great results. Mike, if you please, will you kick us off now?
Sure, thank you very much. And again, I want to thank our panelists for being here today. And for those of you that are joining us this afternoon in this discussion, we hope to impart the knowledge that you see up here as you go about your days and your months and your years and moving into a value-based and outcome-measured world. And so this is a great panel up here of experts, and we will deliver everything that we can within the short period of time that we have. You know, we started out in this, you know, this project era, and now we're in the post-project era, and I think it's interesting that DSRIP's been going on long enough we can use the word era now. But it's really about the outcomes, and there were some unique challenges here because it was a very compressed time period in which to make this pivot, and you didn't have much time at all. So with understanding those challenges, you know, when we last gathered, we were all anticipating this. Well, now here we are 1 year later. So just to kick it off, each of the panelists will discuss the program goals and the focus that they have, and they will also talk about how they've adapted to this programmatic change in DSRIP, and then look at the look at the impact of value-based outcomes and what it's like implementing, whether it's from an administrator viewpoint or an operations director viewpoint, or however you fancy yourself with implementing a value-based program. So each of them has been asked to prepare some comments to get the conversation started, and then I'll come in with some questions. But I think too that you know, if I'm not asking something, if you just want to write it down real quickly on a piece of paper and put it up here, or have the person sitting next to you, I've told them to come up here and put it up here. If we can have time, we'll certainly get to it. But let me just kick it off, and I'll start right here to my left. Megan, just tell us what you've seen in goals and how you're adapting to change.
So our first is really aligning our care with CCBHC, which is a behavioral health initiative throughout the state. There are 7 certified centers. Interval Care is one of them, and Bluebonnet Trails Community Services is another. We're also looking at advancing community-based crisis alternatives that meet the needs of individuals in the community. We're looking at building upon integrated behavioral health and physical health care. That's a really important goal of ours at Bluebonnet as a behavioral health, primarily a behavioral health provider. We're looking at tying in integrated care to that as well. We're really branching out for us, and we're doing provision of medicated assisted treatment. We heard a little bit earlier today about substance use issues throughout our community, and this is one way that we're addressing that. And then the last one is implementing models supporting recovery for individuals with behavioral health needs. So what that means to us is that we're expanding our peer support services. We're looking at family partners. We're really going beyond the traditional scope of care or providers of care and moving into that arm of service to be innovative in that way, continuing from our DSRIP 1.0 projects as well. So those are the 5 that we have identified for DSRIP goals moving forward. How we are shifting this into a system of care, it's so fitting to me that we've been talking about change management because DSRIP is just, we're typically in the weeds of that and it feels like it changes all the time. And so for us, this was a really good test for our agency, and we're continuing to learn and grow in those ways. For us, we really needed to take a step back and see, do those goals align with our strategic plan? Are we implementing things that are in line with what we want to do as an agency? And we have now this opportunity to use those funds to make sure that we're doing that. So again, aligning that with CCBHC, we feel like that's our future and the future of many behavioral health agencies, so we're doing that. We also needed to do a structural shift. We had project managers. Bluebonnet had 21 projects throughout the course of DSRIP 1.0. We now have a core team of our steering committee. We named it. It's now a 1115 Waiver steering committee that includes a lot of our executive management team. I lead that, and then we have some other key directors that meet weekly for 2 hours a week. I'm sure a lot of you try to get meetings on the books with people. Getting that group of people together for 2 hours of a week, to me, speaks to their level of commitment to enhancing the system of excellence through Waiver, which is really important for us as well. We also developed something called a Waiver improvement team, which talks to the strategic continuous quality improvement that we need as we're looking at those outcomes. So when now moving from programs to how these outcomes are affecting our entire system, we needed a new structure to say what's off track, what are we going to do about that? Because I can't look at a project manager anymore and say, hey, your program's off track, can you give me a plan? Now that's us. So we're looking at what areas of our agency are struggling in this, or what areas are doing really well, and so we put a structured team around that and a structured approach to move us forward through that. Of course, data is a huge issue when we're moving through these with outcomes. Again, projects were responsible before for really ensuring the accuracy of that data, and now that we're going system-wide, again, that goes to our core team. So the shift to that data collection in a pullable way across the entire system for us was a really big deal and a really large undertaking. And of course, communication. We heard earlier today about the importance of communication. So for us, that was our 4th approach to really making sure that we were able to successfully, move into this system-based approach. So the impact of all of that, there's impact at many different levels. Of course, with the individuals that we serve, we're hoping that they feel like they are being holistically cared for when they come through our doors or when we see them in the community. We, of course, recognize that putting the dollars behind the outcomes for us allows us to focus the resources, whether it be looking at staffing patterns. Do we have enough RNs in this clinic to really ask BMI and blood pressure questions? Do we have enough LPHAs in the field that can do follow-ups after hospitalization? So the funding tied to these outcomes really allows us to focus our resources on those outcomes and achieving those outcomes, which has made a huge difference in its felt impact for us of moving towards the value-based payment. And we're also with that really trying to balance the clinical experience with that. So for those of you who are working with these outcomes, sometimes it can feel like adding checkboxes and just asking a bunch of different questions to hit these measures. We really are focusing on what does that look like for the client that sits in that chair across from us when we're now asking 10 more questions? And so we're trying to balance that and make sure that we're keeping the client in mind when we're thinking about what this impact would be. We want them to feel holistically cared for. We also don't want them there for an extra 2 hours. So we're balancing that. The last point I think to the prompt is any tips. So I think really knowing as much as you can about your end goal for the data, specifically knowing as much about what those desired outcomes are is really important. We've had to back up a couple times. We've moved too fast a couple times, where we've had to roll something out and then we found, oh, the report actually wants it this way, or that specification, that nuance of that specification, we had it wrong. So taking a breath and really being mindful and thorough in your analysis of what you're trying to do is the best tip that I could give.
Thank you very much. So we're actually going to mix it up a little bit. So Kim, and thank you for leading off. It's always difficult being first, so great job, Megan. But no, I like to jump around and make it interesting for the panelists up here. But Kim, please share your thoughts with us.
Thank you, Mike.
No problem.
So Mike called on me because I'm also a behavioral health provider. We represent Integral Care, and so thank you, Megan, for giving a nice introduction because our goals are a lot aligned. Integral Care serves about 27,000 individuals with mental illness, substance use disorder, or IDD, intellectually developmental disabilities a year. And so, you know, what we're noticing is that our clients are coming in with more needs, and those needs are changing. It's not just the mental illness or the substance use. A lot of that is integrated. 70% of our clients have both co-occurring disorders. And we also are recognizing a huge increase in chronic disease, and as well as some other issues like homelessness. And so what we want to do with our goals is really drive and address all of those needs. So our goals, as Megan mentioned, are providing care associated with certified community behavioral health clinic model standards. So this movement in healthcare is a big breakthrough for mental health. For a long time in primary care, you may have heard of federally qualified health centers. Well, now behavioral health gets a name, and we're really excited about that because that's really you know, standardizing the care that we provide, but also adding validity to behavioral health because it's just as important, and we're starting to see that in our community. The other thing that we're doing is that continued integration of primary care and behavioral health. The mental health population, you may have heard this stat, tends to die to about 25 years or earlier, not due to the mental illness, but to the not due to the mental illness, but due to the chronic disease. So we are beginning to know that that is part of our responsibility to make sure that our clients receive the care that they need. If we're treating schizophrenia, and as Dr. Hernandez mentioned this morning, if one of those clients has colon cancer, you know, we've missed that completely. And so making sure that our clients get to primary care is very important to us. The last thing, our goal is ensuring that we actually look at those social determinants of health. It's really hard to treat mental illness or even a chronic disease to have someone go get, you know, insulin and psychotropic meds if they don't have a place to stay. And so we are also feeling that responsibility as well. So in terms of how to address all of those needs and get you know, a large group of psychiatrists and social workers to embrace that of our clients, we really had to do a cultural shift. And for us, we didn't talk in measures, we didn't talk in check boxes, we talked in care, because we played on the hearts of our social workers, because that's a really good group of people to tug at their heartstrings. And so we said, hey, do you believe in access? Do you believe in trauma-informed care? Do you believe in access for veterans? Do you believe in wellness? And they would say, of course, and this is what we're doing in our clinic. And we said, hey, we got a way to measure. And that's how we you know, incorporated the way that we can start measuring the good work that our staff really believe in doing anyway. And so We had a campaign, we had t-shirts. Our t-shirts were called I Heart CCBHC because that is our name now for care, and got people really excited about that. And so we really didn't even use the name DSRIP or Waiver for our staff. We kind of hid that under, you know, great care and CCBHC, so that was really helpful. Technically, there was a lot of work behind the scenes. Our director will be presenting at a breakout session this afternoon, but we also formed a special ops team, and we spent 2 hours a week building 21 measures, and there were a lot of changes in our forms, and we're also transitioning our EHR. And so on the background, we did do a lot of the technical things that we needed to do to be able to measure some of that stuff. In terms of what I believe in how this is really going to impact care is, you know, data is a very good tool. You know, if you stand on a scale and you look at the, you know, your weight, you may say, oh, I got to do something. And I feel like that is also part of our cultural shift, is becoming a data-driven culture of showing data to our staff and letting them know where we are. And so for one of our measures, which is follow-up after inpatient hospitalization, we were trying a number of interventions, and staff were really excited, but the numbers weren't moving. And so we started looking at the data, and we noticed, well, yeah, we can upgrade our staff and we can have the right credentials, but if staff don't want to, if patients don't want to come to another visit after an inpatient hospitalization, they're just not going to. And so, what can we do more upstream? And then what if those clients, and we're looking at the numbers now, I'm looking at some DSRIP staff that are part of that team, and we're going line by line, because we believe that a lot of staff are being discharged to the Arch and to the Salvation Army. And once they're discharged, they're out in the streets. We can't find them. And so we've got to change our processes to figure out how do we target our work to make sure that we have a good discharge plan for those folks that are homeless. And so each time I get kind of excited when we're not meeting a measure. I wouldn't tell anybody that, but each time you have to really dig into the data and find out the why, and then the why, and then the why. I think that's how you get to better care, because that's going to tell you either you have a problem in your system or you have a problem with a certain client population. And so that to me is what, you know, really can drive outcomes. So ultimately, I think we're just trying to meet the needs of our clients and using data to get there.
Thank you very much. And I think that's interesting, that it's figuring out the why and the why and the why. So it's not always just that first cut, because you can get a false positive reading out of that. So you should just keep digging further and further. It's well put. If I may, Richard, lead us, please.
Excellent. Well, I'll just say, you know, Austin Public Health, we really want to reform the way in which we provide public health. And this is a goal of, we talk with health departments around the state who are engaging in DSRIP, and this is really something that we get really excited about. Because public health is population health, and it reaches people that we hear from other providers, doctors' offices, who have a difficult time reaching these populations. And so we want to reform the way in which we provide public health at our neighborhood centers, at our clinics, and in places where people work, live, pray, and play. We want to make data-driven decisions, as you all have talked about. Data is very important because it helps us explain what we're doing, what impact we're having. But also the stories are important. And so we formed a DSRIP advisory team as well, and it's made up of frontline staff, managers, supervisors, and we're very fortunate whenever our executives make the time to join us as well. And we talk about what are the barriers and what are the successes. We talk about clients that we have seen who have come in and have A1Cs greater than 9%, and what did we do together with them to get that A1C below 9%. And it can be a number on a spreadsheet to show the number of people whose A1C improved, but then also to hear about the stories of the improvement in quality of life for that person. As Dr. Hernandez talked about earlier, you know, it's one thing to be a number, but it's another thing to realize that what we are doing and what we are doing to reform the way in which we provide these health services is impacting people's lives, and it's extending their life. We are implementing a new electronic health record system. We've had databases and other electronic health records in the past, but this is our first department-wide electronic health record. It is a learning experience. We're very fortunate to have a great team of developers and programmers who are helping us through this transition. But as Katie pointed out earlier with our timeline, we often react to DSRIP. And I think we've reached a point where we can start planning around DSRIP and really what we want to do and what we want to accomplish through this program. And so, you know, we have the DSRIP advisory team who work very hard to not only bring their expertise and their knowledge to the table, but also to bring the client's perspective into the discussion. Me and my team, many of us don't get to provide direct client services, and so it's really that team of colleagues who bring that voice into the discussion, and it's so valuable. This is a paradigm shift for us to go from outputs to outcomes, and that way of thinking that we have to screen so many people is reinforced through other grant requirements or through our own performance measures at our health department. And so really kind of taking a step back and saying, okay, yes, we may have screened 10,000 blood pressures, but what does that do to improve their health? And as we know, just screening someone, just asking a question, just telling them to lose weight, quit smoking, does not make them do it. We have to work with them, and we have to keep in mind, I guess I'm skipping down to the advice part, is remember to engage clients in their health changes and in their health discussions. We as providers can write a prescription, we can do the screening, we can provide the information, but the clients are the ones that are going to have to do the hard part. And so we have to figure out what are their motivations for making this change. Just like we have to find out what our stakeholders' motivations are for supporting DSRIP, we have to discover what our clients' motivations are for making changes in their own life. We've been looking a lot at behavior and change management. Megan, as you said, DSRIP is change management. DSRIP is change. And, you know, for so many years, we've measured success in one way, and as kind of the motto of today is change sucks. But once we get through that rough part and come out on the other side, I think most of the time we look back and think, wow, why did we ever do it that old way? But it's rough for us as providers, it's rough for clients, but we have to keep in mind that grand vision that we talk about. And we're really excited. Well, how many people do I have to see this month? It's not about how many people you see, it's how many changes are you going to make this month? How many improvements are you going to make this month? How many motivations are you going to identify this month? And So we're really excited to be able to start talking in that way.
Well said, and you made some points that you talked about the stories and knowing the motivations and behavior and change management, and it really does require you to not just look at healthcare as a transaction or just a brief encounter, but it really is a long-term partnership with another human being. I think we lose sight of it sometimes. But Richard, I think your points are real salient because it reminds us, deep down inside, why are we all doing what we're doing to begin with anyway? Well said. So, Barbara, you've picked up the microphone several times now, and I'm not gonna go against a good idea. So go for it.
Good afternoon. I work for the Community Care Collaborative, and we're a little bit of a unique organization. We administer the local indigent care coverage program called the Medical Access Program. Community Care Collaborative is a collaboration between Central Health and Seton, and our district goals are to increase access to health care, improve the value of care, and improve patient health outcomes. And our population are the Travis County residents who are uninsured and live at or below 100% of the federal poverty level. So 100% of our district population and our population in general are uninsured. So we don't deliver or we don't provide healthcare. We work with community partners, and we have contractors that we work very closely with, and we consider them more partners than contractors. But they're partners, and they're the ones who actually do the patient care. And so in working with them, when DSRIP 2 first rolled out, we got together, we talked about what are their strategic goals, looked at the measures that were possibilities to see if we could select some that were in line with the strategic goals of our partners, as well as the CCC, to make sure that we're not going off into left field or trying to work on something that's really not of interest or at the time. So we ended up selecting measures that were for the most part, in line with our organization's strategic goals. And from that, it is all data-driven, most certainly, very much so data-driven. And we looked at what is it that needs to happen in order to provide better health care along with capturing the data correctly. And some of that meant changing protocols, some of that meant changing screening tools, and some of it is not just screen the patient, but make sure that there is follow-up to the care. For our partners, it is looking at the whole patient and working as a team to provide that care and maximizing the usage of their staff. The physician is not the only one who can provide the care. There are a lot of support staff who help deliver that care. Looking at their patient population to see who is needing a breast cancer screening, who is needing a colonoscopy, and reaching out to those patients, whether it's through a text message or their outreach team to get those patients in and set an appointment for them. Part of that also is, what are the barriers that those patients have to accessing health care? Is it transportation? Do we need to coordinate a ride? We've worked with a company called organization called Ride Austin here in Travis County, where we've brought the patient to the doctor's office so that they can get the care. So trying to overcome those barriers so that the patient can access care. We have, in our district program, we have 36 measures that were selected. And so we are looking at what patients would hit more than one of those measures and trying to see what can we do to optimize the care once they're in the clinic. Sometimes our patients, they don't want to come back for that second visit. So we want to make sure that we can provide them as much care as possible when they're there at the clinic the first time. We're also looking at if somebody is not performing or it isn't making it into the numerator for these measures, a lot of it ties back to the data. What is it that kept them from hitting the numerator for that measure? Seeing if we can change a protocol in the clinic, seeing if there is an access issue. We recently had a situation where a patient went to the urgent care and ended up having to go to the emergency room when the issue could have probably been taken care of in the urgent care, so that patient now affects one of our measures that has to do with a partnership we have with Seton. So we're trying to look to see where is it that we can strategically improve access to care and performance of care. My advice from my perspective is really get to know those measures very well and work with your IT department to see what can be extracted from the electronic health record. Some of this data is not discrete and it's in words, and see if we can change the EHR so that it can be pulled out, because a lot of the work is there, it's just not able to be captured because it's not able to be extracted. Another part is to make sure that the executive leadership of the organization is in the beginning, in the process of selecting the measure and understanding how this is going to impact our company. I'm very fortunate to have Dr. Hernandez as my boss, and so he's very passionate about this, and I've learned so much about DSRIP and about patient care and the delivery of care from him, and so bringing our executive leadership into the fold is not difficult for my agency, but I do understand how difficult it would be if there was not that willingness to sit at the table and find out where our goals are and what we want to do with regards to DSRIP.
So, just so we'll know, and I'm keeping track of this, so Dr. Hernandez has been quoted twice and given a positive, it sounds like he's a really great guy to work for, so, yeah. Lydia, before I go to you, I wanted to point something out that Barbara said, that the level of outreach that's involved, it goes beyond just a phone call or a text message. It is bringing transportation to you so that you can connect with care. Tell us, just off the top of your head, what, in terms of the transportation experience, how do you think that's going right now? According to plan, any surprises there? Any pleasant surprises?
We just looked at some data the other day, and somebody might be able to correct me, but I believe we provided in the last year about 2,500 rides, roughly, and I think for me that's a surprise. We're looking at different approaches to it. This was a pilot project to begin with, and so we were just kind of seeing how it goes out of the gate, and it was kind of labor intensive, and so we're looking at other ways to coordinate those rides without having basically a dispatcher in our office. So I feel like we have a solution, and we're going to see how that works.
So to put that into perspective, if you said 2,500. So if a patient panel could be anywhere between 1,000 and let's just split it down the middle and say 1,200, 50, that would be the equivalent of having two providers having 100% of their patients show up over the course of a year, basically, just to kind of put that frame of reference to it. So that's a huge outcome. So thank you for sharing. Please.
I'm going to talk about both Dell Seton Medical Center and Dell Children's Medical Center's programs kind of pushed together because our approach has been very much the same. And just for a little bit of context, my team also supports another DSRIP program under Seton Highland Lakes, which is in RHP 8, and Providence Health Center, which is in RHP 16. So we actually have 4 performing providers for a total of around 55 measures that we're responsible for. So it has been a lot of data work. We've all had to become more of an expert than we were before in that area. Just a quick sort of recap when we talked last. Dell Seton Medical Center is really focusing on measures related to hospital safety. Obviously, we are a hospital-based organization, and so that is of paramount importance to us. Also, diabetes and heart disease management, as well as primary and preventive care, cancer screening, and chronic pain management. Dell Children's Medical Center is also focusing on hospital safety, and our pediatric population is, of course, very vulnerable, and we want to be sure we're providing the best possible care within our 4 walls there. But we're also looking at chronic disease management in pediatrics in the areas of asthma and diabetes as well. These are focuses that are aligned not only with the community needs assessment that was done in 2017 for RHP7, but these are the populations that strategically our organization is trying to do a better job of providing care to. So we were fortunate in that we were able to look at the new program structure and the new menus and have those discussions with our executive leaders to identify this is work we need to do anyway. Let's use this program as a stepping stone to accelerate our improvements in the care of these populations and in these outcomes. Specific activities so far have really been focused on reducing variation of clinical practice. So a patient who goes to the Trinity Clinic and is diabetic and is in need of a foot exam gets the exact same foot exam as a patient who goes to our McCarthy Clinic and is diabetic and is in need of a foot exam. So making sure that we're setting those standards of care. And also really focused on utilizing lean and high reliability principles in our improvement plans. So standard work, job aids, standard workflows, these are crucial elements to our improvement plans. And also really that deference to expertise. So no one knows how the clinic functions or operates better than the people who are working in that clinic every single day. And so we want to make sure that we're engaging those people, and we've worked through our clinical and operational leaders to take information back to those frontline staff and say, does this make sense to you? Is this the performance level that you would expect based on what you see? Does it look like we're capturing everybody? Is this the correct understanding of how you operate in this area, and making sure that we're getting that feedback. We've also been working very hard, and some of my wonderful analytics folks who are going to be speaking this afternoon are here. We're blessed to have them. They have been working so hard to make sure that we are capturing all of the criteria correctly and that we are interpreting the measures correctly. And then we're translating that into a visualization that can be easily understood by people who haven't been sitting in 7 months of meetings to get the horrible detail of all of those measures. We need people to be able to look at it and understand, am I on track or am I not on track? And then be able to get enough information to know where am I not on track and I need to ask more questions. So that's been a huge area of growth for us in our DSRIP program, from our first round of projects to where we are now in terms of how we've matured in our ability to communicate that performance data. We have actually made some progress so far towards achieving outcomes, particularly in some areas where we had already begun some work prior to all of this work with HHSC around submitting RHP plan updates and things like that. We already were focusing on some of these areas. So we have seen some early gains related to the hospital safety measures and some of our disease-specific admission rates, where we've been really focusing on improving how we're delivering care for those folks. Like some of the other panelists have mentioned, I think having the right accountability structure is been really important in our transition from a project-based to a system-based approach. We no longer have 20 unique project managers who are responsible for their little piece of the pie. We have to have an accountability structure that includes the people who can actually make decisions and influence change in this specific department or in this specific clinic, and making sure that we have the right people in place. And then it's really been a lot of communication and education. We had put together a little road show that me and my team took to all of our performing providers and invited all of the executives, most of whom did show up, which we were very grateful for, and walked them through how the program was changing and what that meant for them and what we needed from them in order to be successful in that change. And then we've been really asking those clinical and operational folks to educate us. I am not the subject matter expert on how our ambulatory clinics run. We needed to find those people and ask them probably an annoying number of questions so that we could understand the implications of what we were asking them to do. And then being very collaborative with understanding that my team is the only group in the organization who does DSRIP as a full-time job. Everybody else has patient care areas that they're responsible for. They have other things that they are responsible for in the organization. And so how can we help be extenders of their expertise and of their teams to make sure that we're successful? I think one of the big challenges with moving from project-based to system-based into value-based programs in general one of the questions that we've gotten a lot is, well, who are our DSRIP patients? And it's everybody now. We no longer have these discrete projects where you're at a single location looking for patients who have a single diagnosis, and then you're going to do X, Y, and Z for them, and we're going to count how many times we do that, and that's how we're going to earn our money. It's now a matter of everyone who walks through the door gets all of the clinically appropriate care, and here's what that means, and here's how it's done, and here's how it's documented, and here's how it's being measured. We figure out the DSRIP measurement bit behind the scenes. And so we've really tried to include that in our messaging as we've been transitioning, that this is about delivering the highest quality care to everybody every time if they're in our care. And so I think that's the core of value-based programs is don't worry about, just worry about the presentation of the person in front of you. And clinically, what are their needs? What would be clinically appropriate care to deliver? And then making sure that our caregivers have the tools and the job aids to know how to deliver that care when it's presented to them. We really tried as much as possible to shield our frontline staff from all of the sort of intricacies of the DSRIP measurements. The other thing in terms of sort of learnings for implementing value-based care programs, I think, is managing expectations and patience. You're not going to see overnight changes in your numbers. You really have to be very thoughtful in managing those expectations and thinking through what are your process measures, what are your leading indicators, how will you know if you're on the right track while you're waiting 12 months to see if you've been able to have an impact on someone's A1C that is sustained. And making sure that you have an evidence base to draw from so that you can clearly make those assumptions that if we're doing this, we should be seeing this effect. How will we know if we're seeing that effect? What can we measure in the meantime? But it takes time to really demonstrate that return on investment in value-based care. And so you have to be mindful of not making rash decisions that this isn't working, we need to try something else. So understanding sort of how long you need to be monitoring before you know if you're on the right track or not.
Thank you. You mentioned, and I wrote this phrase down, deference to the expertise, and that's a holistic approach to the whole design process around some of these outcome-based programs. But talk about, I'm going to use the phrase huddle frequency on this. How do you operationalize that? Is it a weekly meeting? Is it a monthly phone call? How does that work?
It varies a little bit from team to team. We have, with our ambulatory group, for example, who are sitting in the back, thanks for coming, guys. We meet with them, I think, every 2 weeks.
Okay.
We have multiple emails and phone calls in between, but then they also meet with the clinic staff every 2 weeks in sort of a formalized way to review how are things going. Let's look at your data. Do we see movement in any direction? Hopefully it's the right one. If not, why not? What's going on? How can we help? And we have some teams where they've been doing this stuff a long time and they know what they need to do and they just sort of report out to us. Like our hospital safety teams, we have our infection preventionists, we have our quality specialists, we have all sorts of people who that is the work that they live and breathe, and they certainly don't need me telling them what they should be doing. But we still have at least monthly touch points with them just to say, so here's your official DSRIP numbers. How does that compare to what you're seeing? What are you seeing in terms of trends that maybe we're not picking up yet, but that we should be on the lookout for? Where can we help you with messaging, to senior leaders who we may have an opportunity to speak with as well? And what resources are you maybe having trouble finding that we could help with? So just still trying to provide that active support without getting in their way.
That's great. Thank you. Ann.
So under Central Texas Medical Center, as part of our system, we have a series of primary and specialty clinics that are called Live Oak Health Partners. And under the initial phase of the waiver, our project was the development of the Live Oak Health Partners Community Clinic. The clinic is located in San Marcos. It serves thousands of patients, but primarily it serves Medicaid beneficiaries in our community and also those that are low income or uninsured. Throughout 2017, we had almost over 8,000 encounters. It's been a very, very successful clinic. We also recruited a primary care physician, Dr. Stephen Richardson, and he's just been a fantastic addition to the clinic. He's dedicated there full time. We augment his services with nurse practitioners. And what's really been great with his addition to the clinic is that we can serve patients that have very complex medical needs. And many times in the low-income population, they've put off care. We heard about that this morning. They delay care, it becomes rescue care. And so what could have been potentially something simple that could have been managed really becomes something that's more complex. And so having a physician dedicated to that clinic has been really great. Under the waiver renewal, we chose to focus on diabetes care. And we selected that for two reasons. One, in the community needs assessment that Central Health did really showed the prevalence of diabetes in our community, but also we see that as certainly a very strong comorbidity in the population, the patient population that we serve at the community clinic. So what we decided to do in the pivot from the project focus to the outcome focus was to leverage our access point through the community clinic for primary care, and now to focus on better management of our diabetic patient population through regular clinic visits, diagnostic testing at the point of service, prescription management programs, and education. And that's been our focus under the renewal of the waiver. I think Richard mentioned this, I think everybody on the panel's mentioned this, but patient compliance continues to be a real struggle. And we still have a fairly high no-show rate for patients for scheduled appointments. So what we wanted to focus on under the waiver, our core activity was the development of a chronic care management program. And under this program, registered nurses have telephone contact with patients, in this case our diabetic patients, on a regular basis in between physician visits to see how they're complying with their physician's plan of care. So how's your diet? Are you watching your weight? Are you getting exercise? Are you taking your prescription meds? Are you going to be at your clinic appointment the next time it's scheduled? So that was the program that we felt was going to be the best to serve our patient population. We identified a third-party vendor to provide chronic care management services. It was a vendor out of Florida. And we were ramping up for deployment. We were really close to starting this program. And they abruptly closed their doors in June and declared bankruptcy. So we were like, oh boy. So we grieved for about 4 hours. And then we realized we couldn't grieve for 5 because we didn't have enough time. Because things under the waiver changed so quickly. So what do? You pull up your bootstraps and you say, okay, we're going to go to plan B. Because that's what the waiver is. It's change, it's pivoting, it's being flexible. So we really felt that chronic care management was the right activity, the right approach for our patient base. So we opted to stay with that and identify a new vendor, which we did. So we've identified a new vendor, and I've told them, I said, boy, if you guys close your doors, that's it. I'm done. But I think they're going to be really great, and we should be able to have that program in place right after the first of the year. So we're really excited about that, and we think it's going to be the right thing. I think lessons learned, other than being flexible and prepare for anything, is to, and we've talked about this morning, but is to really engage your key stakeholders. That's critical. And for us, it's not only just hospital leadership, but it's the folks at our clinic. It's the frontline staff. It's the MAs. It's the phlebotomists. It's the nurse practitioners. It's the administrative staff. So they understand what we're focused on, what our strategy is, and what we're trying to do. Because I'll tell you what, that clinic staff, patients have a lot of trust in who they see. They trust their physician. And so that clinic staff can really tee up your projects and really get the patients to buy into what you're trying to do. So I think that was one of the big lessons that we learned. The second was don't abandon what you started. And for us, it was the community clinic. So we've implemented a patient navigation program from the hospital where unfunded patients, whether it's an inpatient admission or an ED discharge, We set them up with a follow-up appointment at the community clinic. They're given a voucher. That visit is free. So we're really trying to address utilization patterns, get folks away from using the ER for primary care, link them up with the right level of care on an outpatient setting so that we avoid some of those preventable complications, readmissions, and unnecessary ED visits. So those have been the lessons learned. The waiver has probably been the hardest thing I've done and the most rewarding thing I've done. And I really enjoy these stakeholder forums because when you get stuck in the minutia of the data collecting and you're stuck in all these metrics, it's really nice to kind of look out and say, gosh, we've done a lot of great things for our community. And I'm really looking forward to the next 4 years.
So we'll take the next 4 seconds to grieve, since we're on the short grievance cycle here. But and you said something about clinic staff teeing up these projects. So just pick one aspect of your experience, and if you think about the time that you first sat down at a meeting around the table and said, okay, we have this project and it's going to look like this, from the point that it was operational, what was that time span like?
From the time we decided what we were going to do to the time we rolled it out to the staff?
Yes.
I would say it was probably, again, things had to go so quickly with the waiver, I would say probably 6 weeks.
Okay.
It was really, in the scope of a project, it's kind of a short time frame, but like everybody said, you didn't have time, because we were really ramping up. But it was, we started out with education with the staff, and what is a chronic care management program? How do we think that will benefit our patients? What are the nuances to it? What are the expectations of you as staff members to help us be successful? So that, I think, was very helpful. Granted, we haven't rolled it out yet, but I think we're going to be in a good position when we do, because the staff will already know what we're focused on.
Thank you. So I'll throw these questions out there. I'll throw them into the mix here. And so whoever wants to take it first, don't be bashful. But the phrase "beyond traditional" was used, and we tend to think about medicine or health and health care as there's a provider and there's a patient encounter, and then you go to the next one. So, thinking beyond tradition, what are some of the big surprises that you've seen in terms of delivering health care and driving towards outcomes that have not exactly been what you thought they would be? They would be the non-traditional, the things that you didn't learn in formal education that you now see working very well. Line forms to the left. Oh, that's...
I did.
That's a
I thought I
juke.
had
You can't do
something
that,
to say.
yeah.
I guess I am pleasantly surprised at the response we've had to outreach, to meeting patients where they are. I mean, whenever we look at the numbers, our outreach programs are outpacing our brick and mortar programs at an astounding rate. I mean, almost double what our brick and mortar services are doing. And that's not to diminish the work that brick and mortar services are doing, but that is to say the importance of those social determinants of health.
Right.
How important they are to a patient's health and life, where you take down that transportation barrier, or you take down that stigma barrier, or you take down that access to health care or health insurance, or who's going to pay for the prescription, the doctor's visit, the screening. You see that people want to be healthy. And traditional health care, as I see it, does not provide that opportunity to a large number of people. And so DSRIP and reform and the untraditional health care reaches those folks that traditional health care is not going to.
Interesting. Anyone else want to take that? Kim, I saw the wheels turning earlier, so I know it's there.
I think it's the pace. you know, part of it is the drive in policy changes and managed care rules, but part of it is what our clients are demanding from us. And so I think what we are providing and what they are expecting from a provider is changing. And so we have to be adaptive and
is it
more
is it
agile.
changing because of DSRIP, or is it changing because
I
the
think
overall public expectations
I think
change
it's the
when it comes to
public
brain health?
expectation. You expect the text messages. You expect to be able to go to one doctor and handle a number of needs. You know, the way that our work schedules are working, we expect extended hours and weekend hours and nighttime, you know, and urgent care to be available on Sundays. And so having a traditional healthcare center be able to be more agile and adapt to those needs more quickly, I think is what we're all experiencing. And DSRIP is one aspect of that. But in behavioral health, we have CCBHC, we're moving to value-based payments. And so all of that is really kind of forcing us to move more quickly. And those of us who are really experiencing success are trying to anticipate that before it happens. And so DSRIP 1.0 was great because we started a lot of that. And so as we were building on that and moving towards DSRIP 2.0, it's like we've, you know, built some muscle and are a little bit, you know, not as shocked at how fast we have to move.
Yeah. So the converse of that, we have just a couple of minutes left, but I want to explore the premise that if you learn something, a demonstration project is by definition not a failure, because you are demonstrating what won't work, what not to spend resources on. So does someone have a hypothesis that was proven to be wrong that they would like to share? Something learned that we don't ever want to do again?
Well, I had the hypothesis, if you build it, they will come. And so I really thought we would shift behavior from using emergency departments for primary care to the clinic, and that wasn't the case. You know, that has occurred a little bit over time, but you really have to work hard to change those utilization patterns. And you really have to develop trust, you know, cultivate that trust and engagement.
And this gets to the
with
behavioral
patients.
and the change management.
Yeah,
I
it
think
really
everybody
does.
touched on in
yeah,
some respect.
That's a work in progress for us. I'm not sure about the other providers, but that definitely is a work in progress for us and something we really need to continually focus on.
So let's get past 2021. What does the headline read about healthcare? Does value-based, does it change things, let's say on a magnitude 1 to 10, 10 being changes everything completely, 1 being changes a teeny bit. On a scale of 1 to 10, how does the headline read? Megan.
I mean, I think that when I think about value-based payment and all the complexities that go along with that, at the end of the day, we're here to help people. Like that's why a lot of us get into this field. I think that's why many of you are in the room. And so hopefully that headline will be, yes, value-based payment is working and look at all of these great outcomes. So I think my initial side was, man, I hope so, because that's why we're here. Someone mentioned earlier when they were asking for a statement of change about the disruption. And the thing that I've noticed with from a staffing perspective is our staff have, with such grace, accepted this disruption that we're asking them to do, and really have been engaged and are enthralled with this idea of we're asking you because we really care about how our clients are doing, and that's why our staff are there. To improve the health outcomes of people. That's why they get into this work. That's why we get into this work. And so I guess my answer is I really hope that that's our outcome of this, because that's what we're here for.
So Barbara, how will the headline read in 2022? Better to volunteer than be voluntold.
Exactly. So I really feel that our partners are very passionate in the care that they're giving. And with the changes that we're making, these are protocol changes. This is the way care is given, utilizing a care management team to provide the care to the patient to where they're getting maybe that case management attention that they need to maneuver the system. The healthcare system is not an easy system to maneuver within if you're not familiar
That's what
with
I've
it.
read, yes.
Yes. And so I feel that, and then we're able to provide with our partners some care that we're expanding our care. We're able to bring hospice care to our patients, and that improves their end-of-life situation, and it also keeps them from going to the emergency room, which is not the most comfortable place to go when you're dealing with those kinds of stage of disease. We're expanding dental care to our patients. Dental caries is one of the highest rates of disease, whether it is considered a disease. So being able to provide, I really hope that our system is sustainable, and I feel like we're making changes that are.
And you use the phrase "we," and I think that shows the power of partnerships. And so in the instance of the Community Care Collaborative, it's the partnership with Seton that I think helps us get there. And I think many of you have partnerships, but the one theme that I've heard is that no one went at it alone. Everybody had stakeholders, you had partners, and you were able to capitalize on those strengths and make it work. Lydia.
One other point I just wanted to make about value-based models that is sometimes not talked about, I think, quite enough, is the administrative burden of operating under those models. We've all talked about how data-heavy this DSRIP program is and how complex and intricate the specifications are and the protocols are. That's value-based care. You have to be able to measure something and measure it consistently across providers in order to demonstrate that value that you're then being financially rewarded for. That is an administratively heavy process. And so you need analysts, you need subject matter experts, you need programmers, you need IT support. And then you also need all of those people who coordinate that technical side with the clinical care. And I think if you're looking at moving from fee-for-service to a value-based program, you have to set the expectation within your organization that there has to be an initial investment in the resources needed to do it well.
I just, similar to what colleagues up here have said, DSRIP is very data heavy, and one of the last requirements that we had for our projects that continued on to DSRIP 2.0 is cost benefit analysis. And it's really unfortunate that that requirement for the projects came at the end, because that information would have been very useful at the beginning. But a couple of our projects were found to not be cost beneficial, meaning they didn't divert enough costs in the healthcare system for what we were paying to implement them. Now, what I told folks was, to some aspect, I don't care how much it costs. If we save somebody's life, prolong somebody's life, get them immunized for preventable disease, I don't care if it's cost beneficial. But it did show us in both cases that we have some work to do on how we're collecting data and how we're reporting data. Because that was really a big barrier, was the research team had this data that we had collected because we didn't know that we were going to have to do this cost-benefit analysis, or we would have collected different data. But they had to kind of extrapolate and make some assumptions based on the data that we have. So going forward, data collection is a very big discussion for us. But I hope what the headline will read is that value-based programs are the way to go. But I don't want to get lost in they're the only way to go. Because even if there is no financial benefit, there may be a community benefit. And I'll say that because whenever we shared those cost-benefit results with our executive team, I'm one of the few programs who's still in the finance department, the first conversation we had was, well, then should we continue to pay for these programs? And I had to make the case, let's take a step back from that. Let's look at how we can improve these programs so that they do become cost beneficial. And I was very pleasantly surprised, not surprised, I was pleased that the leaders of the department and the staff of the program, we could have figured out how to do what we were already doing cheaper, or we could have figured out how to do it better. And they were all on board with figuring out how to do it better. And I think that's the spirit of DSRIP, is we identify what's not working and we figure out how to make it better.
And I think you're right, the headline will read, value-based care does make a difference, and I think you'll see it in the equity that we're able to bring about in people's lifetimes today, not 2 or 3 or 4 generations from now, but today. So ladies and gentlemen, please thank our panelists. Very informative. Thank you very much, all of you, for participating, and have a good rest of the afternoon.
Mike, thank you, everyone. One more round for our panelists. Do so much hard work and can come speak to us and tell us about it so eloquently. We are going to move into the final sessions of the day. It's a break. We have 2 breakout sessions. So I want to explain how that's going to work. The first session we are going to have, I think we've talked about it before, is about data visualization. So we've got some speakers among the DSRIP providers here that have some examples about how they are taking the data they have and visualizing it so it can be best communicated to providers, to other staff, to policymakers, whoever needs to see and then react to that information. We're going to be talking about that on this side of the room. While we're out for our break out here with some refreshments, the hotel staff are actually going to pull the wall in between in our ballroom and separate it, because on the back half we're going to be of the room, we're going to have some small group discussions about specific strategies you all are using to achieve the metrics that you may have in common with other providers in the room. This is really an opportunity to kind of dig down into the details of what your DSRIP activities are, what measures you're trying to improve on, and if you've got colleagues from other organizations working on the same outcomes that you are, this is the time to come together, share ideas, what's working for you, this has worked for me, and really kind of dig into that and build some partnerships where you might share patients or other things. So Laura Rosen, a new staff person on our DSRIP team right here, she's going to be moderating this session back on our common metrics. Carol Saucedo on our team, whom you know, is going to be moderating the data visualization session in here. And since our day will end after those breakout sessions, I just wanted to say thank you again for being here as a part of this group. And some things that I really hope you'll take away is remember the why. You know, I think we really got a chance today to connect to why we're really doing here. It's not just spreadsheets, which are so critical and we love them. There are people's lives behind that, and I know you all know that. We've got a real opportunity to be strategic about how we're making change and to use our own personal power. John talked about that earlier, to really achieve the goals in your organizations that you need to, so we can come to this end goal or the next stage where value-based care really is the best way. And then use this opportunity in these breakout sessions to really develop those partnerships that you can rely on going out of here to continue the success for the remaining part of DSRIP. Remember, our website is texasrhp7.org. All the materials are there, and get in touch if we can provide any more information for you. And so with that, let us go on our break. We will get started, I'm counting, at 2:25 to start our breakout sessions. All right, thank you.